Maybe you can start the meeting.
Is my slide shared, sir? Good evening to all. I'm really honored to have this webinar on this evening. And without the help of Dr. Khurana, who is the master brain and the energy behind this whole webinar, this would not have been a dream which has come true today evening. And really thankful to you because you believed that I can take the lead to start the Trivandrum study group, Khurana sir. And I'll try my best to give justice to your thoughts and your beliefs, sir. Without wasting much time, let us go to the panel because it is a much awaited talk. Sorry that I put twins, are they double trouble or not? They may or they may not be, but the topic which I was planning to tell is about monochorionic twins. And my slides are not moving. Okay, yeah. You are seeing so many beautiful babies there. They're all really any couple would like to have. And this is what the aim of the obstetrician and the fetal medicine specialist too. But do we get this all the time? Maybe, may not be. That is the whole point which triggered us to discuss regarding monochorionic twins this evening. I'll take 2 minutes to discuss why I am worried about twins. If you take whole of the morbidity, mortality in multifetal gestation and higher order gestation, if you see the slides, you can see the singleton. The percentage of the babies who are delivered less than 32 weeks is close to 1.5%, while it is almost 10 times in multiples, that is in twins, and it's about 3 times in triplets and almost 6 times in quadruplets. And those who are delivered less than 37 weeks also is about 5 times more in twins compared to singleton. And the infant mortality rate, to my surprise, is almost 5 times compared to singleton in twins. Most of the time, we really don't know what are happening to them after they are born. And this one more slide where I'm just trying to compare the dichorionic twins versus the monochorionic twins, where you see that in DCDA twins is about 20% in preterm premature rupture membranes, but it goes another 5% added in monos. And growth restriction also, it is almost double. It's about 10% in your dichorionic twins and almost 20% in the monos. And when you come to the gestation age of delivery, especially in monos, less than 34 weeks. If you look at that, it's about 15 to 16% in your dichorionic twins, but it is almost 23% in the monochorionic twins. And same with the weight discordance, which is about 10% more with your monochorionic twins. So when we look at the babies who look smiling to us, they look similar, they wear the same dress, they have the same birthday, they do everything well in the postnatal period. But some of them really cause agony, dilemmas, and ethically difficult decisions to manage the family. So let us not waste our time beyond this because I have a very heavy, very esteemed panel today to present before you. And I welcome Dr. Vivek Krishnan, Dr. Bimal Sahani, Dr. Bijoy Balakrishnan, and Dr. Meena Navakumar to join the stage. And without any introduction, my expert panelist, Dr. Khurana, who agreed to be one of my panelists in spite of me being a junior person to start this panel. So I'll welcome you all for this show and let us take the breath and wait for another 1.5 hours to listen from all these expert panelists to know more about twins and learn more about twins from them. And the topic which we intend to share today is complications of monochorionic gestation. Every topic which we are taking today is a topic for discussion for a whole day by itself. But unfortunately, I'm given only an hour and a half. So we will take the whole scenario together today and wait for more to come in the coming webinars. It is really my pleasure to introduce Dr. Khurana. I'm not doing justice by introducing Dr. Khurana to this team. I know that I'm doing an overkill, but as a moderator, it's my job. He is the man who has started, who is behind the SFM, the whole webinars. Every day, I think he's doing one webinar now. He's the chairman and consultant of reproductive ultrasound in Delhi. and is a professor, School of Health Sciences, International University, and is a past president of Society of Fetal Medicine and is editor-in-chief of our main journal, which is a Journal of Fetal Medicine. And when we decided about this webinar, Dr. Khurana told me one thing, that you can have whoever you want in the panel, but I want a young talent who come into picture. And I had no doubt to introduce my colleague, she was my student in DNB in KIMS, who did her FNB from Fernandez, Hyderabad, one of those energetic young talents which I have seen in the last few years. And she is very active in her high-risk pregnancy care. He is very eager in presentations, publications, and managing the labor ward and critical obstetrics too. And with all pleasure, I welcome Nina to this August meeting, and the stage is all yours. And I'll start with the case scenario here. Usually we get a reference from periphery or from an obstetrician. You get a scan report or just a piece of paper which says twin pregnancy without knowing what it is. And it's huge lots of dilemmas when we really don't know whether they're monochorionic, dichorionic, when was the conception, what is the CRL. So we are taking you through another 15, 20 slides, how to take care of the first trimester for these babies and then take you to the second trimester. So this guest, 24-year-old patient who has got 2 years of non-consanguineous marriage, second gravida with a previous miscarriage, is a spontaneous conception, who came to us for an aneuploidy screen. You can see the screen, the first baby has got a CRL of 52 and the second baby has a CRL of 66. Okay, this is something which we see in the common practice. And the CRL discordance is about 20%. And we have done an NT also for her. And Nina, I want you to take this difficult scenario, that how to date a pregnancy with a discordant CRL. I think you can start sharing your screen now, Nina.
Sure, ma'am. Thank you so much, ma'am. And good evening, everyone. So thank you, ma'am, for the kind words. So coming to the scenario.
Nina, I think you should share your screen now.
Yes,
for that, I think I should stop sharing, right?
Yes.
Thank you.
So the topic given to me is the first trimester screening, the dating as well as the screening in twins. So coming to about the dating of the twin pregnancy, may it be monochorionic or the dichorionic twin pregnancy, there is a dictum that may it be singleton or a twin pregnancy, the dating should be done according to the crown rem length in the scan, which is done usually the NT scan, where the CRL measurement is from 45 to 84 millimeter. That is from 11 weeks to 13 plus 6 weeks of gestation. So ideally, the dating of pregnancy to be done less than 14 weeks of gestation. Now, how do we date a pregnancy in twin? So in case of twin pregnancy, both the twins may not be having the same biometry. One may be small, other may be big, or both may be small, or both may be big. So in the first trimester is the ideal time where you need to find out and do the dating of pregnancy. And the dating to be done according to the CRL of the larger twin. Why do we date according to the CRL of the larger twin? This is because if we take the CRL of the smaller twin to date the pregnancy, then it may give a false reassurance that the smaller twin is still growing appropriately, and we may even miss the fetal growth restriction in later part of the pregnancy. And that is why even the mean CRL is also not taken. Always we have to date the pregnancy according to the larger twin CRL. And if it is an IVF pregnancy, it is a dictum that we have to date the pregnancy according to the embryo transfer date, that is dated using the oocyte retrieval date or the embryonic age from fertilization. So this is a scenario up to 14 weeks of gestation. So after 14 weeks of gestation, you have to date the pregnancy according to the larger head circumference of the twins. Along with the dating of pregnancy also, the chorionicity determination is also very important, especially when we do the first trimester scan for a twin pregnancy. So mainly to differentiate whether it is a dichorionic twins and monochorionic twins. So we all know how do we get monozygotic twins and dizygotic twins. Again, according to the number of days of division of the fertilized egg, in a monozygotic twin, again, it can form into dichorionic diamniotic twins, monochorionic diamniotic twins, monochorionic monoamniotic twins, or even conjoined twins. And we all know that the complications are more for monochorionic pregnancies. So why, when, and how do we determine the chorionicity in twin pregnancy? When, that is usually with the NT scan from 11 weeks to 13 weeks and 6 days of gestation. Why is that period chosen? Because at that period of time, the amnion and chorion have not yet fused. After 14 weeks of gestation only, they will fuse. Then how do we determine the chorionicity? The standalone, lambda sign, or the T sign. So we get lambda sign in dichorionic pregnancies, which is the membrane thickness at the site of insertion of the amniotic membrane into placenta, while there is no insertion of the placenta into amniotic membrane. That's why we get a T sign in monochorionic diamniotic pregnancies. And in monochorionic monoamniotic pregnancies, intertwin membrane will not be seen. And there usually we see the cord entanglement that can be identified with the color Doppler. Also, another thing which we can look for is the number of placental mass, but that also is not very specific for dichorionic monochorionic pregnancies, because even in dichorionic pregnancies, we expect two different placental masses, but there can be in many situations a single fused placenta. So most of the time, it may not be, it will be easy to determine by lambda sign or T sign in the NT scan to determine chorionicity. But there will be cases where it will be difficult. So if it is difficult with a transabdominal scan, we have to go for a transvaginal scan. Again, if it is difficult, we have to get a second opinion. And all the images of the chorionicity should be documented, and also it should be in the records for future reference. Like in a referral, if you're sending patient to another hospital, these images should be attached along with their records. A word about amnionicity. Less than 9 weeks of gestation, amnionicity can be determined by the number of yolk sac, but that also to be determined, documented, where we need to differentiate between the monochorionic diamniotic and monochorionic monoamniotic twins. And MCMA twins definitely need a tertiary care center management with expertise in fetal medicine. And why it is important to determine the chorionicity? So as I said, definitely complications are more in monochorionic twins. And there are certain specific complications which we see in monochorionic twins, and so needs frequent monitoring. And in twins, only way of monitoring is the scans, including the Dopplers. And also, the timing of delivery is different in monochorionic and diamniotic twins. Monochorionic, we have to deliver by 36 weeks, while in dichorionic twins, we can wait up to 37 weeks of gestation. So from the statistics which is available from the previous literature and the data, we can see the monochorionic twins, the complications like SFGR is 14%, SFD is around 2%, TTTS 15%, TAPS 3%, and TRAP is 0.1%. So here comparison is given between the singleton, dichorionic twins and monochorionic twins. Miscarriage, perinatal mortality, preterm birth less than 32 weeks, fetal growth restriction, and major structural defects are all significantly more in monochorionic twins.
So Nina, I'm understanding that determining the chorionicity is very important in the first trimester itself. And you very clearly told that the sensitivity to ascertain whether they are mono or di is best in the first trimester. So let us give one take-home message from whatever you have said now. We will never accept a scan report from any sonologist or a fetal medicine specialist without making very clear that they are monochorionic or dichorionic twins in the first trimester itself. Because when they come to the second trimester, it is going to create lots of confusions regarding whether you're going to label them as mono or di. But with an element of doubt, we always take them as monos. But sometimes you see, as I presented in the last case, sometimes you see that there can be a discordant CRL. Though you know that they are conceived together, one can be about 10 millimeters less than the other one. And we see the discordant NT also. So can you just take us through the clinical implications of how this is important in counseling the patient and taking up further care?
Yes, ma'am, sure. So as already stated, there will always be difference between the twins, even in monozygotic twins as well as dizygotic twins. So the first trimester, the important discordancy is in the aspect of crown ring length or the nuchal translucency. So the crown rim length discordancy is stated when there is a disparity more than or equal to 10% between the larger twin and the smaller twin. Why does this happen? Because in dizygotic twins, it occurs because of the different genetic potential because they are paternal twins. While in monozygotic twins, it can occur because of the unequal early division of cell mass, and also it can happen because of the modifications which can happen to the zygote post division. So always the discordancy has to be defined with the larger twin as a standard group. And there is a formula for the CRL discordancy, that is the CRL of larger twin minus CRL of the smaller twin, the whole divided by CRL of the larger twin. So what is the one proved thing of CRL discordancy? If it is found at 7 to 10 weeks of gestation, is it is found to be predictive of single fetal demise at 11 to 14 weeks of gestation, that is the ND scan period. It has got a detection rate of 74% with a false positive rate of around 5%. But as a whole, when it is looked into, it has got a pooled predictive risk of only 52%, which means it is not a reliable predictor of the birth weight discordance or other adverse pregnancy outcome in twins. But when there is a CRL discordancy or an NT discordancy, it definitely warrants a detailed ultrasound assessment, as well as in indicator cases, fetal karyotyping also to be done. So from the stats again, it can be seen when there is a CRL discordancy, there can be a chance of having a pregnancy loss, birth weight discordance in the later part of pregnancy, selective fetal growth restriction, as well as preterm birth. And it is seen even the birth weight discordance as well as preterm birth in monochorionic and diamniotic twins, it is almost 2 times. Dichorionic twins, it is almost 2 times. While the most significant thing associated with CRL discordancy is in the monochorionic twins, the birth weight discordance is seen almost 3 times. So coming to about the nuchal translucency discordancy, and that is said to be discordant if there is a difference of more than or equal to 20%. So the discordancy of NT is seen more in monochorionic pregnancies, and it is usually seen in around 25% cases of monochorionic pregnancies. And that is an indicator of early fetal demise or development of the severe TTTS, especially early presentation in more than 30% of the cases. But if the discordance is less than 20%, then the risk of complications is found only in less than 10% of cases. So compared to the CRL discordance, NT discordance is found to be more predictive towards the adverse fetal outcome in monochorionic diamniotic twins. But another thing to be kept in mind is that neither the NT or the CRL discordance is likely to modify the already fixed the intensive monitoring which is required for these very high risk pregnancies, especially the monochorionic pregnancies. So just a word to touch upon for the completion's sake, in twins, the chromosomal screening in twins, like in singleton pregnancy, in twin pregnancy also, it's well accepted to go ahead with the first trimester combined chromosomal screening with maternal age, nuchal translucency, the double marker free beta HCG as well as the PAPA. Along with that, we can add on with other additional markers like nasal bond, ductus venosus, and tricuspid regurgitation. And the detection rate in twins is found to be around 94% with a false positive rate of almost 0%. So, but it is shows that it is almost comparable with the singleton pregnancies. But the thing which has to be remembered in the twin pregnancy is that when there is a vanishing twins which have measurable fetal pole, it is advised not to go ahead with the biochemical screening. In that case, we have to do the chromosomal screening only with the maternal age and the nuchal translucency and other additional markers. That has got a detection rate in dichorionic pregnancy of 86%, in monochorionic pregnancy of 87%. Another thing to be kept in mind is in IVF pregnancies, we should always ask for the age of the donor. In the donor ovum or donor embryo case, that has to be asked as a leading question because most of the time it will not be told in IVF conceptions, because the maternal age in this case has to be, the donor age has to be taken for the calculation of the risk. And the most important thing is in dichorionic twins, with this screening, we get the risk per fetus, while in monochorionic twins, with this screening, we get the risk per pregnancy similar to as in a singleton pregnancy. So is there a role of non-invasive prenatal screening in twins? Till few years ago, it was not very much advisable to go ahead with NIPS in twins, but nowadays the evidence is coming. Even in twins, it can be used. It has got for trisomy 21 a detection rate of 98% with a false positive rate of 0.5%, almost 89% for trisomy 18, but it is only very low sensitivity for trisomy 30 with a sensitivity of only 66%. So the problem here is in NIPS, even if it is coming to a higher risk, we are not able to make sure which baby is having high risk. So we have to confirm with the amniocentesis separately from the both sacks.
Thank you, Nina, for this enlightening session. But we cannot just close this session without talking about screening for preeclampsia, because I'm more worried about maternal medical disorders than talking about the NT alone. So can you just touch upon in a few seconds, how do you screen for preeclampsia in multiples, especially in monos?
Yes, ma'am. As you told, actually, the preeclampsia incidence is higher when compared to the aneuploidy incidence. So definitely, preeclampsia screening is warranted in twin pregnancy as well, similar to the singleton pregnancy. So it is actually a controversial area where still it is in the research period only. Completely, we don't have an evidence to tell that this is the way that preeclampsia screening in twins has to be done. But the combined preeclampsia, extended preeclampsia screening, which is done in the first trimester, it is found to identify more than 95% twin pregnancies who will later on develop preeclampsia, may be early or late onset preeclampsia, term or preterm preeclampsia. So how do we do the combined preeclampsia screening? It is based upon the maternal factors, the history, as well as the maternal characteristics, the ultrasound with the uterine Doppler mean uterine pulsatility index more than or equal to 98th centile. The other school of thought is more than or equal to 95th centile. Mean arterial pressure and the biochemical markers, the angiogenic markers to be more specific, with the placental growth factor as well as a PAPA. So as I told, it can identify more than 95% case of preeclampsia in twins, but the difference from the singleton is that it is achieved at the cost of 75% screen positivity rate, which is definitely higher than the singletons. So when there is a limited resource where it is not possible to go ahead with the uterine Doppler or the PLGF, we can do the screening with the contingent screening, maternal factors, and mean arterial pressure. And the detection rate of this combined preeclampsia screening to indicate a delivery less than 32 weeks due to preeclampsia is almost 100%. In less than 37 weeks, it is 99%. So regarding twin specific charts, whether it is available or not, certain research prospective studies have formulated certain twin specific charts for preeclampsia regarding the specific mom values for uterine Doppler as well as other angiogenic markers, but it found only a minor increase in performance of the model. So to conclude, the algorithm for the singletons can also be used in twins for this period. The high risk, how do we define? When the risk is more than or equal to 100 according to the preeclampsia screening, then those women will be categorized into high risk group, and those women we will start with ecosprin 150 milligram according to the ASPRI trial, ideally to be started less than 16 weeks of gestation, and it can be continued. And in these women also, the mean arterial pressure, uterine artery pulsatility index will be increased, while the PLGF and PAPA decrease. So comparing with the singletons and the twins, one difference is that the PAPA value, actually, the decrease in PAPA value is not much in twins compared to the singletons. And another thing is the PP13, another angiogenic marker, the decrease. Actually, they both, it is found to be a little more higher when compared to the singleton pregnancies, even with who are at high risk of having preeclampsia. So the role of ultrasound Doppler, uterine Doppler, even uterine artery also, there is an increased placental mass in twins. So it is said that the uterine artery mean resistance is lower compared to the singleton pregnancy. So it is ideal, if available, to use twin specific reference ranges. And the sensitivity will be more with a reduced false positivity rate if we go ahead with twin specific ranges. But another thing which was observed is in first trimester, there is a higher uterine artery resistance in monochorionic pregnancies than dichorionic pregnancies. And in monochorionic pregnancies, it is similar to that seen in singleton. So another thing is in the cell-free fetal DNA, if the fetal fraction is low, it is also a predictor of increased risk of preeclampsia. So according to the chorionicity, in case of preterm preeclampsia, almost it is similar risk for both monochorionic and dichorionic twins, but The otherwise, in total, when we see the risk of preeclampsia a little higher in dichorionic pregnancies. And the latest research which has come in this preeclampsia screening twins is the EVENTS trial, where they suggest to use the posterior risk according to the new distribution of log-10 more values of the uterine PA, MAP, PLGF according to the G8 delivery with P, but still it is not widely accepted. So as I said, the prevention of preeclampsia, like in singletons, it is with the echospirin, and it is found to reduce the incidence of preeclampsia before 32 weeks by about 90% and before 37 weeks by 60%. And it was found that the addition of PAPI to the combined risk screening did not actually improve the overall detection rate, but it is included as a part of the preeclampsia screening in twins also. Thank you, ma'am.
Thank you, Nina. It was just a short, crisp, but very detailed description. Corona, sir, would you like to say your comments now or at the end?
I think we comment here to remind everyone that the most important message, there is no such question as reporting a twin pregnancy. We have to report what type of twin pregnancy, because it has huge implications. Every single follow-up will be based on that, and the prognostication will be based on that. One of the options in such pregnancies, the monochorionic ones, is a termination of pregnancy, and we have to regard that very seriously, take that very seriously. And in the first trimester, we need to stratify exactly what we're going to be doing. So that was conveyed very beautifully. Thank you so much, Nina. That was very beautifully put. We also know that we can do a lot about preeclampsia, never mind if we have a 75% detection and a 75% rate of saying that, okay, they are at risk. It doesn't matter. We will still be able to help them out. Most importantly, in this data, we have to look at it the other way around. And that is that, yes, monochorionic pregnancies are tough, but if selective FGR occurs in 14% of these pregnancies, then it does mean that 86% will not have a selective FGR. If we have a TTTS in 15% of monochorionics, diamniotic, then it does mean that 85% will not have TTTS, and therefore it's not a hopeless situation. What, of course, has to be told to the patient in general is that when we look at monochorionics in the long run, irrespective of whether they're complicated or uncomplicated, there is a definite risk of abnormal neurodevelopmental outcomes, which is out of proportion to the general population. And are you willing to accept that or not? If they're willing to accept that, that's very nice. If they're not willing to accept that, then they're justified in requesting for a termination of pregnancy if they so want. And otherwise, it's an absolutely marvelous thing. I won't even say it was a summary. It was exquisite detail and terrific pre-digested material.
Thank you, sir.
Thank you. Very well done.
Thank you so much, sir. Without wasting time, we have much more dynamics to share. So I'll share my screen. Nina, can you stop sharing there?
Yes, ma'am. Yes, ma'am.
So without wasting time, I'm going to the second part of my journey. This is, our twins have now grown from the first trimester to 18 weeks as they're coming for a target scan. You can see that my fetus A is on the maternal right and fetus B is on the maternal transverse. The A has got normal Leica with a single deepest pool of 5 and the B is subjectively reduced with a deepest pool of 2.8, and they have a common posterior lobe placenta. And coming to the growth, you can see the baby A is adequately grown for the gestational age. Everything is around the 70th centile, while my smaller baby is around the 3rd centile to -2 standard deviation. And if you look at the Dopplers on the down portion, the normal Dopplers for twin A and my baby B also has normal Dopplers, if you want to call that, but the umbilical artery shows a higher resistance flow, which is beyond the 99th centile for the gestational age. So what is it? I really don't know how to talk to the couple. Then I thought of this gentleman who is always passionate to talk about growth restricted babies. He's none other than Dr. Bijoy Balakrishnan. And I will not introduce him, but I have to take the privilege. He is one of the most, no, I really don't know how to spell how he speaks. he really attracts the crowd, the master man who takes any topic to the crowd's mind. So Bijoy, welcome you to the first online meet of the Trivandrum study group to take this case scenario and carry it further to make the whole evening more enlightening to the public. Thank you, Bijoy.
Thank you, ma'am. If you can stop sharing, I can share mine.
Yeah. Wow.
Good evening, everyone, and thank you, ma'am, for inviting me for this first online meet of the Trivandrum study group. And yes, it's becoming kind of cliche to be known as the IUGR person in fetal medicine, but it's something that I like to do. So yes, dealing with growth restricted babies is especially useful because it's an area where we can create a huge difference. It doesn't matter what kind of therapy we can do or intervention we can do. It's the growth restricted fetuses that we can make a huge difference in. Now, when we talk about monochorionic pregnancies, growth restriction in monochorionic pregnancies is very different because it's not about the placental functioning, basically, it's about unequal sharing. And that's the principal difference in SFGR when it comes to monochorionic pregnancies. In dichorionic pregnancies or in singleton pregnancies, you're looking at a bad placenta, and that bad placenta is the reason why the baby is small. And that is why a large proportion of dichorionic pregnancies that have growth restriction are also going to end up with preeclampsia. Whereas in monochorionic pregnancies, it's because of unequal placental sharing. The placenta is essentially good, but the share that is there for the smaller baby is going to be lesser. And that's why that baby is going to be smaller. So when we talk about unequal sharing and placental dysfunction, that is where the difference lies. And to complicate matters further, this monochorionic pregnancy has got vascular communications running across. So you have a small baby with a smaller share of the placenta. And to make things more complicated, you have vessels running across from one baby to the other. Now, the vessels that run across are also different. You have a deeper anastomosis and also a superficial anastomosis. The deep anastomosis is something that I'm not going to deal with it because I'm sure Bimal sir will be talking about it when he's going to talk about TTTS. So a deep anastomosis is basically an arteriovenous anastomosis that runs from the artery of one baby to the venous channel of the other baby. And an arteriovenous channel can take blood from one direction to the other, from fetus A to the fetus B. It cannot take blood in the opposite direction. And it's basically the reason why you have TTTS. But in SFGR, what changes the scenario is the superficial anastomosis. Now, superficial anastomosis are arterial anastomosis. Now, as the name suggests, blood can go in any direction from one side to the other. And the principal factor that determines the blood flow direction is basically the volume of blood. So any side where the volume of blood accumulates, it goes back into the other direction. And that's why it has a protective role in TTTS. In TTTS, you have an arteriovenous channel that is pushing in blood from one direction to the other, and the protective AA anastomosis takes all that volume back and pushes it back into the first fetus. And that's why a superficial anastomosis is very, very useful in protecting against TTTS. And it plays a crucial role in SFGR. What happens in SFGR, as you know, the placental share is less, and therefore the blood volume is going to be lesser on the side of the smaller baby. And this arterial anastomosis will allow volume transfer from the larger baby into the smaller baby. And because of that volume transfer, that smaller baby is going to grow. And that's why it's called as the rescue transfusion. And in spite of having an unequal share, it is the arterial anastomosis which keeps the smaller baby alive and allows it to grow. But it is a double-edged sword, and I'll tell you why shortly. But the biggest advantage here is that the natural history of monochorionic pregnancies is changed because of this arterial anastomosis. If you have a singleton pregnancy, and if you have growth restriction, and if you see that the umbilical artery is showing absent end diastolic flow, You know in your mind that this baby has got maybe around 3 to 4 weeks before the DV reverses and before you have to take this baby out. But in SFGR, when you have absent end diastolic flow, that baby can remain in that state with absent end diastolic flow for a period of around 11 weeks. And why that happens is because of this arterial transfusion which takes place from the larger baby to the smaller baby. And so if you do the maths, if you have a baby that comes in at 20 weeks, monochorionic pregnancy, and you have an absent end diastolic flow in the umbilical artery, it's not like a singleton. You don't have to panic immediately. You know that you have around 10 to 11 weeks if everything goes well. 20 plus 11 is going to be 31 weeks. And by the time this baby really has a problem, that is, its DV begins to reverse or it shows signs of cardiac decompensation, by that time, this baby's lungs would have been mature and you can take this baby out. And that is why the natural history of monochorionics is going to be different from singletons or dichorionic pregnancies. But it is a double-edged sword because I told you it depends upon the volume. So when there is pressure fluctuation in either of these fetuses, which could be from anything like fetal movements or hiccups or even cord entanglement on one side or cord compression on one side, there is going to be volume transfer from one baby to the other, from the high pressure zone to the low pressure zone. And this volume transfer can cause brain damage, can cause neurological problems for either of these babies. And that's why there is a possibility of neurological damage even when you have alive babies on both sides of the membrane because of this large AA anastomosis. And in the unfortunate scenario where one baby dies, then the entire blood from the larger live baby goes into the dead fetus and thereby creates a neurological problem in the normal fetus, surviving fetus, and sometimes there can be co-twin demise as well. And therefore, when you're managing monochorionic pregnancies with SFGR, two things have to be kept in mind. The first thing is the natural history, which means you have time, which means that if you have a baby that has an absent end diastolic flow at 20 weeks, it does not mean that this baby is going to die. You have time. That's the first message. The second message is that you cannot allow this baby to die, any of these babies to die, because if either one of these babies dies, you're going to have a huge problem that could be ranging from neurological damage to co-twin demise. Now, having understood the basic physiology behind growth restriction in monochorionic pregnancies, let's try to understand how to diagnose them. As in singletons, when you have any of these babies less than the third centile, you have poor perinatal outcomes. So definitely that is growth restriction. There is no confusion there. So if your dates are correct, and if you have a baby that's less than the third centile, directly it's going to go into selective growth restriction. But if you have a fetus that is having 25% discordance, any of these two contributory factors, that is, you have a 25% discordance along with an abnormality in the umbilical artery, or if you have an estimated fetal weight less than the 10th centile along with discordance or an abnormal umbilical artery. And here is where it differs from singleton, in which you're using the single criteria of AC alone. AC alone is never used in singletons. And the reason why it's added here is that because there is similar growth potential in these two fetuses. And if you have a small AC with a discordance or an abnormality in the umbilical artery, then again, you would classify these fetuses as SFGR. Now, once you have made that diagnosis, the next thing is to classify them. Now, the classification is important because, again, it tells you about the natural history. Now, stage type 1 would be where you have diastolic flow within the umbilical artery. Type 2 is where you have a persistent absent or a persistent reversed end diastolic flow in the umbilical artery. And type 3 is where you have intermittent absent or intermittent reversed end diastolic flow in the umbilical artery. Now, as I told you before, the placenta is not bad in monochorionic pregnancies. Therefore, a type 1 fetus can remain in type 1 till around 34 to 35 weeks because it does not put a huge strain on the heart. Whereas in type 2, there is a strain on the heart. And the reason why the heart fails is not because the placenta becomes more bad. It is because the heart, which is trying to pump against this resistance, begins to fail. And at the same time, it is being supported by the rescue transfusion that is coming from the other side. And therefore, you have got a long latent period of around 11 weeks before you can say that the DV is going to be abnormal and that you have to deliver this fetus. Now, type 3 is kind of tricky here, because in type 3, these fetuses have actually the least amount of placental share when you compare it with type 1 and type 2. So they have a very small placental share, but they have a very large AA anastomosis. And this large AA anastomosis is going to support this baby with very less placental share for a long period of time. But anything that happens for good has also got another side to it. And that is because of this large AA anastomosis, which is usually greater than 2 millimeters in size, you're going to get a huge pressure fluctuation between these fetuses, which are totally unpredictable. And the only way to make that diagnosis is to look at the umbilical artery. And in the umbilical artery, you're going to get this pattern of intermittent absent or intermittent reversal. And you can pick this up only if you trace the umbilical cord at the point of origin. Now, you're sure about your diagnosis, you know it's SFGR, but there's always this thought in your mind, is this TTTS? Is this TTTS? Am I looking at TTTS or SFGR? I don't want you to think about anything else except LICA. If the LICA is high in the normal growing fetus, it has to be TTTS, because it tells you something. What does that tell you? It tells you that there is volume transfer from the smaller baby to the larger baby, and that volume transfer is the reason why you have polyhydramnios. If you don't have polyhydramnios, and if the baby is having normal LICA, that means there is no volume transfer coming from the opposite side, so it's plain and simple SFGR. So the only thing that you have to look for, I know it's not that simple in real clinical life, but the only thing that you need to look for is whenever you look at a baby that you have that is small and there is some amount of volume discordance or LICA discordance on either side, ask yourself, are you looking at polyhydramnios? And if you're looking at polyhydramnios, your diagnosis is TTTS. If not, it means just wait. Before you label it as TTTS, you can still call it SFGR and wait till it fulfills the criteria. So if it is TTTS, you would treat it as TTTS and not as SFGR, because the treatment modalities are totally different among these two variants. So now coming to the management part, we made the diagnosis, we differentiated it from TTTS, and now we have to manage this SFGR. As I told you, we need to look at prevention. We need to prevent the smaller baby from dying, but at the same time, we should not induce iatrogenic prematurity while trying to save the smaller baby. And therefore, it is a balance between both. We can't allow the small baby to die, and we also can't allow the larger baby to be born too early. So in type 1, as I told you, there is going to be diastolic flow. The placenta is not going to worsen. The heart is beating against OK resistance. This baby will go till around 34 to 35 weeks, and you can safely deliver these babies closer to term. So that's the easy part. In type 2, you have to decide whether the smaller baby is going to survive till the period of viability or not. And depending on that, you decide whether you go in for expectant management or selective termination. So the question you're going to ask yourself is the smaller baby going to survive till the period of viability? If the answer to that question is no, then you go in for selective termination. If the answer to that question is yes, then you go in for expectant management. Now, it's easier said than done. So how do you make that call? So to make that call, there are three important criteria that I can give you. The first criteria is the gestational age at which you're going to see SFGR. Is it less than 24 weeks? The degree of discordance is greater than 35%. Is the abnormality in the umbilical artery very severe? Is it reversed end diastolic flow, or is there a DVPI greater than the 95th centile? So when these three criteria are met, what does it tell you? It tells you that there is discordance, the placental share is less, this heart has to beat against this severe resistance in the umbilical artery for a long period of time, and that means it is going to fail usually before 28 weeks, and therefore we have to intervene. If these criteria are not met, then your diagnostic points or your triggers for delivery or selective termination are going to be, I'm sure all of you know this, the ductus venosus, which all of you know is my favorite vessel. And that's the vessel that you're going to look at after you have answered negative to all the questions that we asked in the previous slide. From then onwards, once you know that the discordance is not very severe and that there is absent end diastolic flow in the umbilical artery, You look at the DV and then decide on what you want to do. So if the DV reverses before 28 weeks in a singleton pregnancy, what do? We either terminate the pregnancy or deliver depending upon the parents' choices. Here that we do exactly the same thing. If the smaller baby is showing DV reversal, we terminate the smaller baby. And the methods of termination are different. There's no time to go into that in detail, but I'll just show you 2 clips to the end of this talk. But if you cross 28 weeks, then your triggers for delivery are exactly the same as that you would do in singleton pregnancies. If your DV is reversing before 30 weeks, you take the baby out. Reversed end diastolic flow between 30 and 32 weeks, take the baby out. Almost always, none of these babies go beyond 32 weeks. So you have to deliver them by 32 weeks. And how do you monitor them? Exactly the same way as you would do in singletons. You do your Doppler, and yes, you do your biophysical profile. You look at all these things and make sure that the baby is not hypoxic or acidotic, and follow up this pregnancy till as long as possible. Now, the scenario is difficult in type 3 because in type 3, there is huge arterial anastomosis, pressure fluctuations are going to happen. These conditions are going to be totally unpredictable. So you have to watch these babies like a hawk. And this is one area where the DV is not going to be helpful, because in type 3, the DV rarely shows any problem. The DV reversal is not something that we can wait for, because there is intermittent good flow within the umbilical artery, which takes off the pressure from the heart, and therefore the heart is able to sustain for a longer period of time. And that's why in these cases, we don't just wait for DV reversal, we would directly go in and deliver these fetuses at 32 weeks. So I'll just give you 2 videos on how this selective termination is done. I cannot go into the details. So this is selective termination that we do with bipolar cord coagulation. So this is done usually at later gestations at 26, 27 weeks. And what we do is we grab the cord. It's not easy to do because it slips out of your hand. Once you grab the cord, we try to be sure that the cord is within your grasp by holding it and then doing a sort of a seesaw motion to see whether it moves with the grasper. It's just like any other bipolar forceps that you use. Only thing is the thickness is lesser. And then you just apply bipolar energy, and you can see bubbles coming out, showing you that you have actually fulgurated the cord. And so by doing that, you are cutting off the blood supply from the other side, and any kind of inter-twin transfusion is being cut off. Now you can do the same thing at earlier gestations. If it happens very early, for example, 18 or 19 weeks, and you have severe discordance with all the criteria that we talked about, then we do radiofrequency ablation, where we put in a needle at the point where the umbilical vessels enter into the liver and burn that area, and thereby separating off the circulation of these fetuses. So that's all I have to talk about on SFGR. Now, if Dr. Vidya Lakshmi ma'am can share her case, we can go back and see the case and try to solve that. Ma'am, over to you. You're muted, ma'am. Yours.
Yeah, I have unmuted that. Can
Yes.
you hear me now?
Yes, I can. Yes, I can.
Bijoy, the previous case which we were mentioning was, as you rightly mentioned, was a stage 1 SFGR. So can I just have your views of how you would have taken her, because she was only 18 weeks.
Agree.
So, and she was stage 1 as per your diagnosis. So a quick comment on how you would have done, and then we'll go to the second case.
Yeah, so if I remember correctly from that case, it was type 1 SFGR, 35% discordance, 18 weeks.
Yes.
Yes. So here, again, it doesn't meet all the criteria. It meets the criteria of having SFGR of a greater discordance lesser than 24 weeks, but the umbilical artery is still showing diastolic flow, which means I would think that there is a good latency period for this fetus. So I would manage that baby conservatively and try to push that pregnancy as much as possible. Of course, I would talk to the parents and tell them that there is a chance that this baby may require selective termination before the period of viability. And that's a possibility that we cannot rule out at this stage. Yeah.
So can I just ask you one more scenario, Bijay, because you were mentioning that if it happens in late pregnancy, as I have seen here.
Yes.
This is a pregnancy who has come to me at 24 weeks of gestation. If you see that the liquor is subjectively reduced in the second pocket, it's
Yes.
about 2, and the other is having normal liquor.
Yes.
But when I looked at the Dopplers, and the first baby is growing normally and with all the Dopplers being fine. The second baby is showing absent end-diastolic flow in the umbilical cord, which the ductus venosus towards almost normal. It's about 0.6, which is 42nd centile.
Yes.
But the umbilical PI is something which is worrying me, and that she's only at 24 weeks.
Exactly as I told you right now, because these babies have a long latent period. They have a long period in which they can stay in absent and diastolic flow, which tells you that these babies can do well. They can cross the period of viability, especially since you're looking at discordance after 24 weeks. So in these cases, what I would look at would be the bladder, if it's present or absent in the smaller baby, the condition of the LICA, the biophysical profile, see how the baby is moving, how it is doing, and also look at the ductus venosus and keep a close watch on this baby and try to push this baby as close to the period of viability as possible, because these babies will do well.
Yeah,
These babies will do well.
yeah. Thank you, Bijoy. That's exactly what I did with the fear of IUFD for one of the babies, but the family cooperated, and I'm very happy to tell that with the discordance of 30%, they pushed to 30 weeks, and then we steroid maxel her and delivered at 30 weeks, and both the babies are doing well until today.
I think
So
that's the
today,
most
yeah.
important point in SFGR. In SFGR, it's like the waiting game. You have to see who blinks first. And
Yes.
if you get scared and if you blink and you do something, you might create more harm. So
Yeah.
the best option in those cases is to just wait and watch, and also keep an eye on what you're looking at. If you're looking at severe discordance with severe abnormality in the umbilical artery, then only you will be worried. Otherwise, absent and diastolic flow fetuses have a pretty good outcome.
Okay. Thank you, Corona sir. Will you take up the second case and give us more thoughts on it?
Well,
Corona,
not just taking up thoughts on it, I would still leave that to the super specialists. And I would like to play obstetrician here.
okay, sir.
So let me take on the role of the obstetrician and say, what do? I'm not interested in the logic. I want a good outcome. You tell me and write it down as advice that this is the counseling and this is what I should do. Should I send them back to you to do anything, or should I just carry on, and when do I call them back? We are very lucky today that we have definitions in place, and we're very lucky today that we have protocols in place. I mean, 2021 is a milestone year for us to realize that there is so much consensus on the management of these particular conditions in the monochorionics. And so if I were to really do anything about this, to drive this point home, that look, this is not for the general obstetrician that I am. This is not for the person that I am. I need a super specialist who can truly improve this outcome by so many multiple points. And therefore, I would happily carry on with that. So the case is right back in the court of the specialists.
Yeah,
So,
I'm.
yes, Bijoy, please.
No, I've already said what we're going to do, but if the obstetrician asks me, I would definitely write it down saying that you have to send this patient back for ultrasound at least twice in a week. And we
Yes.
have to monitor these babies very, very closely. And they should not deliver unless we tell them to deliver. Till then, they have to hold on. I know it's difficult, but that's the way we should counsel when we are counseling an obstetrician who is managing that patient, or else they should send it to a fetal-maternal medicine center. Yes.
I fully agree with you. Vivek, would you like to have a difference of opinion here with our two eminent panelists?
You cannot differ on certain accounts even if you want to, because this is protocol. This is protocol, and this is exactly what we follow as well.
Okay. Okay, thank you, Bijoy. Thank you, Khurana sir, for being part of this SFGR panel. And let us move on now because of short of time. I know that the audience would like to hear more from Bijoy, but definitely we'll come back with a whole webinar on SFGR with Bijoy taking the whole show on.
I don't mind something else other than SFGR, by the way.
Okay, next time you'll have something different on your plate, Bijoy. I assure you for that.
Just joking,
Yes.
absolutely fine.
Okay, I'm now going to my third set of cases where this is another lady who has come to me at 19 weeks 6 days, and if you can see that this baby has got totally a difference in the LICA pockets with a single deepest pole of 7 on one side and 2.3 on the other side, and they have the common anterior placenta. And if you look at the growth, the low growth looks pretty okay for the first baby with normal Dopplers, and the growth looks pretty okay for the second baby with also normal Dopplers. So sometimes we really don't know whether it is TTTS, SFGR. There is like a discordance, but not to satisfy anything which we have just heard. We would definitely like to go for the second part of the whole show, which is twin-to-twin transfusion syndrome, or whatever you want to label as. It is a real privilege to welcome Dr. Bimal Sahani, who is the director of Sonoscan Center, Aurangabad, and is the president-elect of Society of Fetal Medicine. He is an academic coordinator, and we have heard him in several webinars by now, and is a co-author for the second trimester guidelines for the Society of Fetal Medicine. It's a principal author for the first trimester guidelines, and co-author for the SFM India-oriented guidance statement for ultrasound. He's got huge presentations to his accord, and his area of interest is mainly fetal growth, Dopplers, and fetal echocardiography. Dr. Vimal, I welcome you to this August audience to break this case scenario to us and enlighten us on the case. Thank you.
Thank you, Dr. Vidya Lakshmi. And
can you share your slides, Vimal? I'll just stop sharing here. Yeah.
can you see my screen?
Yes, yes, we can very well see that. Yes, yes.
Thank you.
Good evening to Kerala, and to the extreme end of Kerala, the Trivandrum, Vimal.
Thank you, and thank you for having me in this elite meeting. You know, maybe it's your first meeting, but you know, all that begins well, ends well. So you've started off with a bang, and thank you for making me a part of this wonderful event. And now, you want me to discuss your first case first, and then move on, or?
No, Bob, for the benefit of the audience, I think you can take your subject first and then break to your case scenario, because I've given you a niche area, which I really am sure that participants are waiting to hear from you.
Well, I think you started off with the case and showing that there is a discordance in the amniotic fluid volume in both. So now we can move on to twin-twin transfusion syndrome. Now, it's of course it's unique to monochorionic diamniotic twins, but again, as you pointed out, that whatever you want to call, so TTTS as such is a misnomer. It is, you can call it as fetal transfusion syndrome. And Bijoy has already spoken about the types of anastomosis. So TTTS occurs when you have the deep, the arteriovenous anastomosis. And what happens with this AV anastomosis is that you have a unidirectional transfusion. So, you know, and he's already touched the topic that you need the AA anastomosis to balance this. And usually when TTTS occurs, the arterial anastomosis is less. And you have an intrafetal transfusion, which goes across from one fetus to another. And so what actually is taking place is that, okay, we have an anastomosis there. The donor, there is going to be a chronic blood loss from the donor, and this would lead to hypovolemia, anemia, hypoxia, and then you have this decreased renal flow causing oligohydramnios. Whereas for the recipient, again, there is a chronic blood gain where you have, one second. You have polyhydramnios, you can have polycythemia, embolization, hypertension, and cardiac failure. So for TTTS to occur, these anastomosis should be large. The AV anastomosis should be large. Once they are large, then you have continuous flow from one fetus to another, and that actually leads to these changes which happen there. So what is the essential criteria for diagnosis of TTTS? The essential criteria is amniotic fluid volume discordance. And again, fortunately, things have been, there is a universal consensus on this, that so what we're getting is an oligohydramnios polyhydramnios sequence. And to call it as oligohydramnios, you have the single vertical pocket or the deep vertical pocket less than 2 centimeters. And for polyhydramnios, an SVP greater than 8 centimeters before 20 weeks and an SVP greater than 10 centimeters after 20 weeks. So you really require this discordance, and you really have to label it as oligo poly by definition before you start calling it as TTTS. Of course, that's, you can see you have an oligohydramnios on one side and you have a poly on the other side, but this not necessarily you would find in presentation. So what, there is a progressive polyoligo that takes place, and you would find that slowly, you would find that the lichar on one side reduces and the lichar on the other side increases. And finally, you end up in a condition where you have what we call as the stuck twin. Because of a severe oligohydramnios, you would find that the one of the twin is stuck. Now this is where the problem is. In fact, quite a few patients who come to me for a scan with a diagnosis of monochorionic monoamniotic pregnancy with in fact actually are TTTS. Because so when you have a stuck twin, you may probably not be able to make out the intertwin membrane, and that is the reason you label it as an MCM, monochorionic monoamniotic twin. But what you need to understand is that you have to wait, and you will find that there is one fetus which is actually not moving at all, and that gives you a clue. Or then you have what we call as the folding of the membrane. So somewhere down the line, you would find a folding of membrane that would be seen, and that actually tells us that there is a stuck twin. So because the whole management, everything would change if you label a TTTS as a monochorionic monoamniotic twin, because we are eventually going to end up with disaster. And that is the reason. So every time that you feel that this is monoamniotic, spend a lot of time, try to look for the membrane, try to look for the folding of the membrane, and see the movements of both the fetuses. And if you find that there is one fetus which is at one corner and is not moving at all, you will find that somewhere around the corner, you will find that there is a intertwin membrane that you are able to make out. And then there are other things that will happen in twin transfusion syndrome. The donor, you will find that you have a very small or a non-visible bladder, whereas in the recipient, the bladder would be enlarged. Then, as Bijoy pointed out about the fetal, the SFGR, so you have the donor which would eventually be small, and the recipient would become large because or hydropic. Then you anemia, because there is a the blood is being transfused from the donor to the recipient. You have anemia in the donor, you have polycythemia taking place there, and then you can have Doppler changes which occur on in both the twins. And hence, the second most important thing becomes is to look for the bladder in both the twins and to document the bladder. It's important that you need to document. You just can't go by your, that, yes, I felt there was a bladder there. No, you put in your color and look for the vital arteries and make sure that what you are labeling as a bladder is not some other, a dilated bowel or something which you are labeling as a bladder there. So the second thing becomes that, and your Dopplers are, of course, very important. So if you find any Doppler changes in either of the twins, so an absent or a reversal of diastolic flow in the umbilical artery, or you have a wave reversal in the ductus venosus, or you have an umbilical vein which is showing pulsatility, so you need to do a Doppler. So Doppler becomes a very integral part of evaluating a monochorionic twins, because these are the changes that we require for staging a TTTS. So are there any predictors for TTTS in the 11 to 14 week scan? People have talked about anti-discordancy, abnormal ductus venosus in either fetuses, CRL discordancy, AC discordance, but then sensitivity of all these signs is not extremely high. Hence, the protocols of follow-up of all monochorionic pregnancies should be the same. So, it's not just that you are finding something, and that is why I'm going to, put this monochorionic pregnancy into higher surveillance, because all these things, yes, they could be predictors, but their sensitivity is not very high. So we just do not rely on the 11 to 14 weeks predictors. We need to have a protocol which goes in. We also need to look for the cord insertion, because we know that filamentous cord insertion for one of the twins is something which can be associated with twin transfusion syndrome. So we are moving on to that. The whole issue about the TTTS is that you have a monochorionic twin, you need to pick this up as early as possible, and hence you need to have a protocol for every monochorionic twin that you need to look for, because see, amongst all these complications, TTTS is the most dreaded one. So forget just TTTS, even for SFGR, for other complications which are specific to monochorionic twins, we need to pick them early, and for that we need to have a protocol. So 11 to 14 week scan we have done. We have confirmed the chorionicity. We know it is a monochorionic pregnancy. After that, you need to do a 2-weekly scan. So you need to do a 2-weekly scan. And whenever there is any suspicion, even if there is a suspicion, you can increase your surveillance and follow up after 1 week. Now, again, the question comes is, unfortunate part, I feel, especially in most of the places, is that we are not picking up these TTTS at an early stage, because this protocol for monitoring in monochorionic twins is not actually being followed. Whatever you write down, you suggest 2-weekly follow-up. Eventually, after your NTs, the 11 to 14 week scan, the patient eventually ends up to you for the mid-trimester anomaly scan, and there have been no scans, and sometimes it is too late by the time the patient comes to you. And hence, I would suggest that even if you don't want these 2-weekly scans to go to a specialist every time, even if you are an obstetrician who has an ultrasound machine, but you do it 2-weekly. And look for the Leica discordance, look for the amniotic fluid discordance, look for any weight discordance, look for at least subtle things that could indicate that this pregnancy is leading into some problem. And then, whenever you feel that, you send them. But at least this 12 weeks, 20 weeks, 28 weeks, and 32 weeks, these scans should be done in specialized centers. And then if you have any suspicion on amniotic fluid discordance, then I think after that, all scans should be done with the specialist, and centers who are well versed with, well equipped with, and have a good know-how about how to go about with the complications of monochorionic twins. And what should we look for in each scan? Of course, as along with our routine, yes, biometry and fetal weight very much. Then the deepest vertical pocket, like her, look for the deepest vertical pocket around each fetus, from around both the fetuses. I don't know from where people have come up with this concept where they try to get an amniotic fluid index coming up in twin pregnancy. And that is, it's not uncommon. You do find reports where they've given you an amniotic fluid index in a twin pregnancy. Then look for the bladder, document the bladder, umbilical artery and ductus venosus needs to be seen. And after 18 weeks, you need to look for the MCA Doppler, because you want to look at the MCA PSV and its moms, because we are also trying to look for the anemia polycythemia sequence. Then we have to stage TTTS. And yes, we have these 5 things which actually help us in staging: the Leica, the bladder, the abnormal Dopplers, hydrops, and IUFD. But let me tell you one thing, that this staging, the Quintero staging, is the one which is followed. It is good enough, but these stages are, they do not follow the complete cascade like we have with our early onset FGR, that, this is going to happen, then this is going to happen, then this is going to happen. This may not happen in TTTS. So because the hemodynamics, we are talking in very simple language, that there is an AV anastomosis, and then you have transfusion taking place from one side to another, but the hemodynamics in TTTS is too complicated. Hence, you can have a stage 1 and then going directly to stage 4, and you may not have the stage 2 and 3 in between. So they do not represent different times during the natural history of the TTTS, but they represent different forms of presentation with possible different prognosis. Hence, but then, yes, this is the one which is being followed. Of course, people have come up with other things also, but the Quintero classification is the one which at the moment is existing and is the one which is being followed. So what does this classification say? That stage 1, you have an amniotic fluid discordance, that is an oligopolyhydramnios situation. The bladders are normal in both the fetuses. The Dopplers are normal, no hydrops, no fetal demise. In stage 2, of course, in all these stages, the oligopoly will be there. But in stage 2, you have that the donor bladder is not seen. In stage 3, you have abnormal Dopplers along with that. In stage 4, you have hydrops in either twin. And in stage 5, you have a fetal demise of one of the twins there. So this is the Quintero staging that we have. But we also need to look for certain things which talk about the cardiac dysfunction in the recipient, because we know that the recipient is receiving more blood. There is hypervolemia that is taking place. So we need to look for biventricular hypertrophy, the atrioventricular valve regurgitations, pericardial effusions, and then changes of right ventricular outflow tract obstruction. Hence, we also need to keep looking at the size of the pulmonary artery and the aorta, look at the comparison between the pulmonary artery and the aorta, look for forward flow across the pulmonary artery. So we need to look for signs for right ventricular outflow tract obstruction. And based on the cardiac dysfunction, we had this CHOP scoring which had come, but not many people actually are using it, but you have this CHOP score, and I'm not going to dwell with it because it itself is going to take a long time. Now, how is the prognosis of TTTS? Of course, if left untreated, 80 to 100% mortality. You have abortions, preterm delivery, yes, because we have polyhydramnios taking place on one side, selective or single intrauterine fetal demise, and then cerebral and cardiac sequelae will eventually going to happen. So what are the management options? We have conservative management, then the most talked about and the most accepted, the laser, the fetoscopic laser photocoagulation, amnioreduction, septostomy nobody does now, selective reduction, RFA and bipolar, Bijoy has just talked about. And then at times, yes, parents opt for termination of pregnancy if you find that you have a high staging of a TTTS. But among all these options, it is only the fetoscopic laser photocoagulation which actually is treating the etiology. So it is basically, coagulating the anastomosis. All other management protocols are either palliative or then, they are actually your selective reduction. We are actually reducing one fetus, but the etiology is being treated only with a laser photocoagulation. Now, what points we need to consider for management? See, I'm not going to get into the depth of management again, because as with SFGR, TTTS management itself, and yes, there can be a lot of difference of opinion based on for the management of TTTS, because it depends upon what is the gestational age at diagnosis, what is the stage of TTTS, what is the condition of the fetus? Is there any discordance in anomaly, discordance in chromosomal this thing, or is one of the fetus with cardiac failure? Then availability of the facility for procedure. Yes, very easy to talk about. Yes, everybody talks about TTTS management laser. How many centers are there which are doing laser? Is that center accessible to the place where you are practicing? What is the cost involved? Can the patient afford to do all that? So all these things need to be taken into consideration when we talk about the management protocols. Definitely laser, yes, the outcomes are very high, overall survival rates of 80 to 90% for at least one fetus. And you have, it's not that, yes, it is a foolproof test. You have a rate of neurological handicap between 11 to 16%. It has its own complication. You can have fetal demise, premature rupture of membranes. All these things can also take place there. But the best outcomes are done when lasers are performed between 16 to 26 weeks. You have different types, methods or how you can perform it, the non-selective, the selective, and the Solomon technique. So what we are doing with laser is we are actually converting this single placenta into two different circulations. So by removing this AV anastomosis, we are giving two separate circulations on either fetus. I won't talk about the non-selective one for the short of time, but what is being done in the selective technique is that you coagulate only the communicating intertwined vessels. So you locate all these AV anastomosis and coagulate them. And in the Solomon's technique, you do this, plus you also, what you do is you join the dots. So along the equator of the the vasculature, you take a sweep and cut, because if you do selective anastomosis, you could still be left with some small anastomosis which you have not coagulated, and hence the Solomon's technique is the one which is now the one which is preferred one. And in follow-up, yes, you can still have persistent TTTS. Yes, it's improving as the experience is increasing. You are finding that, yes, people are doing a wonderful job, and hence this persistent TTTS is reducing over the years. You can have reverse TTTS, where after some time you would find that the one which was the donor actually has gone into polyhydramnios, because there has been more flow going from the recipient to the donor there. And then with, if you have left with small anastomosis, then you can have the anemia polycythemia sequence that can take place there. And this all can happen in 18% of the cases. So it's not, these are all things that you need to counsel your patient when you're talking about the management options there. So the next option is a selective feticide. Now, this is to be done when you have that, when you know that the outcome of one twin is a suspect. One twin has got some anomalies, one twin has got cardiac failure, there's a lot of hydrops there. In such cases, or there is no facility available for laser, then selective feticide is an option. At times, parents choose to go for a selective feticide, because the whole issue is that we are trying to salvage at least one of the fetuses there. And of course, the choices between, early you do the RFA, and after 18, 19 weeks, then bipolar cord occlusion becomes the preferred choice. Amnioreduction. Now, it would come way down when we talk about options, but then in our country, yes, this is one option which could be used, because we are a country with limited resources, the cost factor comes in, but then you can give a chance with amnioreduction, where you're actually decreasing the intrauterine pressure. You need to select those cases where the mother is having problems because discomfort, and then you have it's not just about you doing an amnioreduction to reduce the discomfort to the mother, but even an amnioreduction of the recipient side of the polyhydramnios side helps in improving the uteroplacental perfusion, and it elevates maternal symptoms. But then you can have 64% survival, but again, the poor neurological outcome, the rate of neurological handicap is 29 to 35% there. So management, stage 1, talking about it, people are doing laser in stage 1 also, but then there is a big school of thought which says that stage 1 we need to do expectant management. Expectant management does not mean that you just leave it aside, because there is spontaneous resolution, or the stage may remain stable in 50% of the cases, and so you don't leave it aside, you put them on increased surveillance, and then you have an option of intervening where you find that yes, things are deteriorating there. Stage 2 and above, laser is definitely the option there. 2 and 3, good enough. 4 and 5, again, you need to think about it. Wherever laser is not possible, then serial amnioreduction. And if the outcome of one twin is a suspect, then of course bipolar cord occlusion and or the radiofrequency ablation there. Now, this is this wonderful paper which has come current practice, and where they have given us the protocols, and they say in stage 1, less than 16 weeks, conservative, but consider laser. 16 to 26 weeks, yes, the first line of therapy should be laser photocoagulation, then cardiac evaluation and MRI needs to be done. Greater than 26 weeks, conservative with possible preterm delivery, but again, consider laser. Then in stage 2, 3, and 4, up to 26 weeks, again, laser is the first line of therapy. If infrastructure is not available, amnio drainage greater than 26 weeks, conservative with preterm delivery, consider laser. and in severe stage 3 or 4, selective fetal reduction on patient request. That is what they've suggested. And signs for rescue intervention in conservative management. You have a progressive cervical shortening. Yes, you need to go ahead. You may have to go ahead and do, your cervical encerclage, or and also if you find that there is a worsening discordance of amniotic fluid, go for amnioreduction and signs of maternal discomfort. And if you have a confirmed diagnosis of TTTS at any stage with a discordant fetal anomaly, then invasive testing and selective fetal reduction. And if there's a shortened cervical length, include cervical circlage in the management protocol. Now, surviving twin risk. Now, whichever procedure you have done, and if there is a demise of one twin, the other twin definitely has a risk of neurologic damage. And because even with the TTTS, there could be vascular anastomosis which still remain. And what will happen is there is an acute exsanguination of the survivor into the fetoplacental unit of the deceased protein. So you have, and this eventually would lead to hypovolemia and anemia in the surviving twin. And hence, you need to do a weekly follow-up after any procedure. You can ask for an MRI to look for the cerebral damage there. And just one word line about TAPS. I think Vivek is going to take about it. Yes, but because an anemia polycythemia sequence can be a part of TTTS also, but yes, it can be seen even if the TTTS is laser is incomplete coagulation in laser. And so the diagnostic criteria, the one which we used to follow so far is that an MCA PSV is greater than 1.5 moms on one and less than 1 mom in the recipient. But the current, the new method that has come in is that you rather, they found that if you take the delta MCA PSV, it is more sensitive to pick up an anemia polycythemia sequence. And what is delta MCA PSV is that if there is a difference of 0.5 moms between the two, because at times it may happen that yes, one of them is not meeting the criteria, and then you would probably not be able to diagnose it. And hence, if you find that there is a difference in mom of 0.5 moms between the two fetuses, then you have to think in terms of an anemia polycythemia sequence. So in TTTS, the most important is to determine monochorionicity. If you have not diagnosed monochorionicity, you're not going ahead. Follow the protocols. My only message is, because yes, this webinar today is just to give an introduction to the complications of monochorionic pregnancies. And as Dr. Vidyalakshmi has promised that we are going to come back again with more details in the next you have, like Bijoy says, everything comes in 2 parts. So this also would come maybe 2 or 3 parts. And the success of management is how early it is diagnosed. And that is the reason my humble request to everyone, humble request to all the clinical obstetricians, that if, please see to it that you follow the 2 weekly protocol in monochorionic twin pregnancy, and counsel the parents as regards various options and their outcomes. You don't need to think that, okay, anyway, I'm not doing laser, I'm not doing any of these procedures, and then anyway, my patients would probably not go all the way to Bijoy or Vivek in Kochi or at any other place. I think that is a very, very wrong notion that we have. We need to let the patient know, because lot of these would be very, very precious pregnancies. If you inform them, let them know everything, you would find that yes, some of them would eventually opt for management, further management. So you just don't need to just go ahead and terminate these pregnancies because you feel that your patients are not going to afford it or not going to go somewhere else. My own experience has been that whenever I have spent some time with the patient and given them all the information, it's not all, but some of them have gone and they've got wonderful results coming out of it. So for, twins can be very funny, but honestly speaking, when it comes to monochorionic, for the mother, it is not fun. Even for the people who are practicing, who are treating or managing, monochorionic is no fun. It is all about, You really have to put in a lot of your time. You really have to follow protocols, and then only you're going to do or maybe help the patients. Thank you very much.
Thank you. That was an excellent session, Bijoy. Khurana sir, everybody is waiting without dinner. But if you want to break the first case, Khurana sir, where the clinical scenario was just the Leica discordance because there was nothing else. But the discordant Leica was not classifying it into stage 1 or 2. So how do you take that, Khurana sir? Because she was only 18 weeks, but the Leica was
Yes.
discordant. Yeah.
The moment we find this, we must have our antennae go up. There is no question. And we must know that the most common situation is this out of the treatable ones. Yes, there could be a structural discrepancy in one of them, which we know is rare, but can happen. We know that there can be other scenarios. But again, the single most simple aspect that Dr. Bimal Sani has already highlighted, and that is no compromise. And because of the chorionicity, we do need that 2-weekly follow-up. Once you do that, it's unlikely that you will make a mistake. In this particular situation, obviously a very, very precious pregnancy, we have to do everything that we can do, and we don't want to miss an opportunity. In this situation, if we have all this information that we are seeing on the screen at the moment, we say, look, the next step has to be a clean, very clear evaluation of the Doppler. And we must see that.
Okay. Dr. Bimal, this is the second case which I wanted to put, but the time is very less. But just quickly to take you through, this is a patient who has come with, she's 40-year-old, mind you, she's a primary gravida IVF conception. They want everything under sun at 26 weeks of gestation. The twin A is showing polyhydramnios and the B is showing severe oligohydramnios. And the growth, you can see that the growth is also discordant here. And how to go about, because we know that it is severe TTTS at 26 weeks of gestation, and with severe growth discordance also. Maybe it is an overlap or is part of TTTS. But if you look at my first slide, which are going back, if you're seeing that your stage is now gone beyond stage 2 to 3, now to 4.
This is stage 4 now. So,
yes.
you know, once you are in stage 4, definitely, you know, we are on a very late stage. But then, of course, so I think we follow whatever we've just discussed before, that you know, in this kind of a scenario, this baby eventually is not doing well. You know, the hydropic changes there. So laser can be given as an option, but maybe a selective feticide to try to preserve the other one, try to save the other one. Maybe you know, Khurana sir or Bijoy, who are doing more of these procedures, could probably add on to that, sir.
So let's take one more minute to get Khurana sir to answer or Bijoy to answer, because we are running short of time. Stage 4 in an elderly woman, very precious pregnancy, would you give her a laser, RFA or conservative? Because we are really not sure what is going to help her. I don't want a miscarriage here. I'm her obstetrician. I won't let you, fetal medicine specialist, give me a miscarriage now at 26 weeks. And I don't want an extreme preterm too.
Bijoy, your babies.
Very clever.
I mean, can I take this question? Or?
Yes.
Yes, Bijoy, the ball is in your
Okay.
court now.
Yeah, when the obstetrician says that, you know, I can't take them out early and neither can I do any procedure, it's kind of difficult. But at 26 weeks, we are looking at a very precious pregnancy. This baby is hydropic, so we are looking at stage 4. And here, I would be tempted to do a laser here because the placenta is to my liking. It's posterior, I think, correct?
Yes.
Yeah, so posterior placenta.
I knew that you like posterior placenta.
Yes, because they are easier to do, and they are extremely, I mean, good. The visualization is extremely good. So I would suggest a laser in this case, because the other baby is very small, right? The discordance is how much? What was the discordance?
It was 29%.
29%. So if I was going for selective reduction, I would have to reduce this hydropic baby with bipolar cord coagulation. And I do not have no idea how the smaller baby would survive with that small share of the placenta. So I would try a laser. And I may be successful, I may not be successful as far as the larger baby is concerned, but I don't think I'll be doing any harm for the smaller baby. So I would definitely think of going in for a laser because the placenta is posterior. Now, if it was anterior, I would have my doubts, and then probably I would think of probably reducing the one that is hydropic. Again, it depends on what you're comfortable with. So the posterior placenta, I have no doubt if it's TTTS, I will go in for a laser, definitely.
Okay, Bijoy, thank you a lot for that, because as you rightly mentioned, we have Bahubali 1 today, Bahubali 2, 3, and 4 are yet to come. So we'll leave it for the part 2 and 3.
Okay.
I welcome the most energetic young dynamic speaker for the today's evening, the one and only film star of my webinar, Dr. Vivek Krishnan, to take over. And I don't know, most of you know that he is passionate, is a great orator. I'm staying close to the school where he did his schooling for until his 12th standard. And I'm always proud to see his name in the school board as the topper, school topper, the school leader, and whatever what you want to call him. And this is what I would like you to talk on, Bijoy. The stage is all yours. And every trap has an escape route, as per Vivek. He needs no introduction, but he is a clinical associate professor and head, Amrita Institute of Medical Sciences, Kochi. He is a member of Fetal Therapy Committee at SFM, and to his credit, he doesn't write journals now, he writes only books. And his area of special interest is prenatal screening medicine and acting in movies, to my knowledge, and he is a good anchor. What not is the question. So stage is all yours. Vivek, people are waiting without dinner to hear from you. Can you share your slide?
Yes, ma'am. Thank you for those very kind words of introduction. And thank you for having conceptualized this webinar. Thanks also to SFM for having persisted with these series of webinars. I was just cribbing to my fellows today that I've done 3 this week, and then I stopped for a moment and thought, people like Khurana sir and Bimal Sani sir have been doing 3 every week for the last 1 year, so that we stay abreast with what is latest in the field of in our field of interest.
Thank
so
you.
I have no reasons to crib.
Yes.
Okay, so I will take you through a few case scenarios on TRAP sequence and try and explain the concepts of the TRAP sequence through these cases. Is it full screen, ma'am?
Yes.
Okay, thank you. So now we know that the root problem or the root cause of all problems in a monochorionic twin pregnancy is the fact that they share a common placenta. And when they share a common placenta, there could be issues. One, like Dr. Bijoy mentioned about unequal sharing, or there could be issues due to abnormal vascular connections between the 2 twins. Now, abnormal vascular connections are more common than unequal sharing, which is why you get a lot more cases of TTTS, TAPs, TOPs, TRAP, etc. Whereas unequal placental sharing leads to what we just heard of as selective fetal growth restriction. Now, as Bijoy rightly pointed out, it is the abnormal arteriovenous connections within the depths of the placenta that lead on to TTTS, TAPs, or TRAP. To TTTS or TAPs, whereas in TRAP, the culprit anastomosis is an abnormal artery-to-artery connection. Now, I'll take you through a few cases. As I mentioned, the first case is a 32-year-old second gravida, 24 weeks, referred as MCDA twins. One twin was absolutely looking normal with a good-looking heart. The other twin was a very weird mass of tissue, a blob of tissue, looking more like a monstrous mass of tissue rather than anything what remotely looks like a fetus there. But this monstrous mass did have some vascularity inside, meaning it was a live structure there, but I could not make out any definite heart, head, or any fetal form, despite the best of my ability. Here's a similar case, a little earlier in gestation, around 14 weeks. Again, you could see the thin in the twin membrane. You see one fetus that looks absolutely normal. You could see a very well-beating heart there. And close there in the upper story, you find a very weird looking mass with lots of cystic spaces. I cannot really assign a name to this mass. This is a close-up of that. You could see some elements of the spine. You could see something that remotely looks like a limb there, a lower limb, probably a couple of lower limbs there. But beyond that, to the upper story, everything looks very, very obscure. What you can see is definitely certain cystic spaces all around the fetus. But if I switch on color again, I see that this entity is light because it has clarity, it has blood flow. But again, this is where I would expect to see the heart. There's nothing that looks anywhere close to what we would call a fetal heart. So the diagnosis in both these cases would be a discordant monochorionic diamniotic twins with what we call as the TRAP sequence or twin reversed arterial perfusion sequence. Now the TRAP sequence is a very unique complication, not common. You heard Nina say it's seen in around 0.1% of all monochorionic twins. Now this happens because of a very unique angioarchitecture in this placenta that is designed to develop the TRAP sequence. There are three distinct features that you can identify. One, of course, the two cord insertions would be quite close to each other in most of these cases. In fact, within 15 centimeters of each other. You would also notice that the normal looking twin would have a 3-vessel cord, whereas 70 to 80% of the other twin would have a single umbilical artery. The third point that you would notice is that there is a very prominent artery to artery anastomosis between these two closely inserted cords. So you have cords that are closely inserted. You have one baby with a 3-vessel cord and the other with a single umbilical artery. Now, what happens is very early during the gestation process, somewhere around 5 weeks or 6 weeks after the baby's cardiovascular systems have formed, for some reason, there happens to be a pressure differential between the two. It could be because one of the twins was aneuploid. Remember that even in monochorionic twins, you could have post-zygotic events that lead to discordant aneuploidies and anomalies between the twins. So maybe one of the twins had a problem. For some reason, it had a fall in blood pressure. And I heard Bijoy said when there is an artery to artery anastomosis can allow bidirectional blood flow. You can push blood from one side to the other side, depending on which side has more blood volume or more blood pressure. So for some reason, there happens to be, let's say there happens to be a severe bradycardia in one of the twins because of the cardiac anomaly. So that baby's blood pressure suddenly drops. You have a discordant blood pressures or blood volumes between the two twins, and there is a large open channel artery to artery anastomosis that is there. Now, because of the sudden discordance or difference in blood pressure, the fellow with the lower blood pressure suddenly sucks out blood through this large artery to artery anastomosis. And mind you, an artery to artery anastomosis has 4 times the diameter of an artery to venous anastomosis. So the amount of blood flow that happens through this would be 16 times that you would expect in an artery to vein anastomosis. So that is quite a large amount of blood for a very small fetus. So because of this pressure differential, the small twin sucks out a large amount of blood from the other twin. And I don't know if you've seen people sucking out petrol from bike petrol tanks or scooter petrol tanks. They just suck out with either the pump or they suck out with their mouth. And once the petrol starts to flow, it just keeps flowing. You don't have to keep sucking it every time. Exactly the same kind of phenomenon happens here. Once there is this pressure differential that is created, and there is a significant pressure differential here, and once the smaller twin starts to suck out blood from the other twin, it becomes a never-ending process. So this sets into what we call as a reversal of blood flow direction in the single umbilical artery of this twin. So therefore, eventually, this twin, instead of getting pure blood from the umbilical vein from the placenta, through the umbilical vein from the placenta, ends up being fed by impure blood from the other twin through this artery to artery anastomosis, reversed into the umbilical artery, back into the iliac arteries of this particular twin. So now we know that the blood that comes out of the umbilical artery of the normal twin is going to be impure blood, deoxygenated blood. So whatever little oxygen is there in this blood gets extracted by the pelvis and the lower half of the body, which is why in the case that you saw, you had normally developed or reasonably well developed lower limbs, but the rest of the body gets very, very little oxygen. And therefore you have a disruption of morphogenesis because of vascular disruption. and therefore the fetus upper story, the upper part of the body, including the heart and the head, do not form properly or do not develop properly. Now, this is what happens in what we call as the twin reversed arterial perfusion sequence. And this baby that pumps for both the circulations gets rightly called as the pump twin, whereas the other one, which is being perfused by impure blood from the other twin, gets called as the perfused twin. You may also want to use the term acardiac twin because, as I said, this baby does not often have a normally developed heart. Now, this is the ultrasound equivalent of the same picture that I showed you. This is one of our old cases, one of our early cases of TRAP sequence. You can see very clearly the two cord insertions are attached very close, are inserted very close to each other in the placenta. You see a normal twin with a 3-vessel cord. You see a TRAP or an acardiac twin here with a single umbilical artery and a single umbilical vein. So this is a 2-vessel cord, this is a 3-vessel cord, and you could see the large artery-to-artery anastomosis on the surface. So this picture beautifully illustrates what happens in a TRAP sequence on either side of the circulation. Now, how do I know that this is the artery and not the vein? Well, this is the second case that I showed you. This is a normal twin that I'm trying to sample. I'm sampling the umbilical artery of the normal twin. Where do I see blood flowing? It flows away from the twin. That's why you get stroke upwards. Whereas if I sample the so-called amorphous mass of tissue, the blood flow direction in the umbilical artery is not away from the twin as you would expect, but it is into the twin or towards the twin, which is why you're getting a negative deflection of the waves here. So vis-a-vis to the normal twin that pumps blood into the umbilical artery towards the placenta, the abnormal twin receives blood from the umbilical artery into the body of the twin. So this is how you confirm that this blood flow that you see here is reversed blood flow in the umbilical artery of the acardiac twin. Now, there are several different forms of TRAP sequence or acardiac twins with all sorts of fancy names, very hard for us to remember most of them. The good point is that be rest assured that you do not need to remember them anymore, because these classifications of the different forms of the amorphic twin are considered completely meaningless in contemporary practice for the simple reason that the pathogenesis of any of these is exactly the same. And because the pathogenesis is the same, the management also is no different. So you don't have to rack your brain thinking of how to name the monstrous looking twin that you see. Just call it as twin reversed arterial perfusion sequence or TRAP sequence. Now, this term denotes a very common pathophysiology for all the different amorphic forms that you're going to see in this condition. Not just that, it also explains exactly how you get a different gradation of anomalies when there is a TRAP sequence in place. So the term that you need to remember is TRAP sequence. Forget about acardiac, amorphous, NIDS, so on and so forth. Just give the name twin reversed arterial perfusion sequence in all such cases from now on. Now, what are the problems that you would encounter when there is a TRAP sequence in place? We know for a fact that the acardiac twin is a classical example of how vascular disruption or vascular obstruction can hinder morphogenesis. You have blood flow being hindered, you have blood oxygen being hindered, and therefore this twin does not develop normally, does not have a heart, nor does it have a head, and therefore it goes without saying that it is absolutely incapable of ex-utero survival. Now, the other problem is because most of the oxygen gets extracted by the lower half of the body, the renal system does not develop well as well, and therefore there's a lot of edema that develops because there's no excretory function that happens properly in these twins, except for what would diffuse across the skin. And therefore, you would have severe edema in the acardiac twin in most cases. The other dreaded problem that you would encounter is if this mass assumes huge sizes, as it would if you do not intervene in time, it becomes an absolute nightmare to get them out at delivery, even if you're doing a cesarean section, because you simply would not have anything to hold on to. It will be like a ball, a blob of mass that circulates around freely in the amniotic fluid. You're lucky if you can get hold of a foot or a leg there, but in some cases you might not even have that. You might just have a blob of tissue. It becomes you might have to put in a myoma screw and then take out these babies. So it's really traumatic for the mother as well as for the obstetrician. And that is one of the problems that you can encounter with large amorphic twins. Now, as far as the pump twin is concerned, remember this has to pump not for its own need, but it has to pump for 2 circulations. The other twin oftentimes bigger, if not equal in size to its own. And therefore, eventually down the line, it is bound to develop cardiac overload and cardiac failure. And as a result, high drops. Now, not just that, because of this high output state, it could also end up developing polyhydramnios, and very often, if not intervened, carries a mortality risk of around 50 to 70%, not just from cardiac failure, but also because the other dreaded complication that hinders its survival, which is preterm labor due to these polyhydramnios. Now, this is a third case here. This case typifies what I just spoke to you about, the problems that can happen in both these babies. This is the acardiac twin. You can see how big a mass it can be compared to the normal twin. But here again, you can see that the so-called normal twin with the normal heart and the normal head is completely hydropic because of this extreme volume overload. This was a case that happened last week at 21 weeks of gestation. So as early as 21 weeks of gestation, the pump twin has got into trouble because it's been pumping for not just itself, but for a larger mass in itself. Eventually, as expected, this baby's heart has failed and this has gone into complete hydrops. And this couple rightly chose to interrupt the pregnancy. Now, at the root of all problems that plague monochorionic twins with TRAP sequence is the size of the acardiac twin. Now, unlike what Bijoy says and like saying with FGR, this is one particular state where size does matter, because larger the volume of the perfused twin, higher is going to be the amount of complications for the pump twin, as is this paper showing you. If the estimated weight or the volume of the acardiac twin is more than
Hello? Hello, Vivek?
I think we have lost Vivek's connection,
Yes.
and he's probably trying to log in again.
Can you take a few questions, Corona sir, meanwhile?
Yes, we'd like to start off with questions while we're waiting for Vivek to log in again.
Yes, sir.
And I'm going to start with some of the very basic questions that were asked in the beginning.
Yes, sir.
And the first question was asked by Dr. Bhumika Singh. And the question that she asked was, 2 gestational sacs in early pregnancy, can we label them always as dichorionic diamniotic? Or is there a possibility that one of those sacs actually withered away and that we actually have a monochorionic twin coming up in the second sac? So this question would be I guess, Dr. Vidyalakshmi, you can take that section. It was in the introductory section.
Good evening, sir. I heard the question, and I think Nina had already answered the question in the chat box, sir. Nina,
Yes.
can you just take it?
Yes,
Nina,
ma'am.
please take it. Yeah.
So regarding the if 2 gestational sac is in, it means it is a dichorionic pregnancy, but still we need to confirm with the lambda sign before 14 weeks of gestation. So the confirmatory will come only with the lambda sign or the T sign, even if we see 2 gestational sacs.
Excellent. So we will always try to reconfirm our labeling at the time of the nuchal translucency early morphology scan.
Yes.
The next question is from Dr. Geeta Devi, and she wants to know that in NIPT, can we give separate risk results for dichorionic diamniotic twins? Could we have an answer for that as well?
Yes, regarding NIPS, sir, it is an advanced technology, but the thing is that you cannot have the separate cell fraction. You can only know that one of the twins are affected. So that is a limitations when you talk about NIPS in multiple. So as Nina rightly mentioned, the fetus specific risk should also be kept in mind, because pregnancy specific risk is something which is different in monos.
Yes, that we do have NIPT for twins, but the fact is that we can't tell which twin, which is completely straightforward and understandable. The next question is
So may I just take that on
Yes,
NIPS?
Yes, yes,
Yes,
please,
yes,
Vijay.
Vijay.
If the problem with NIPT where you do not use a SNP-based technique, you will not be able to differentiate between the fetal fractions. But if you're using a SNP-based technique, you should be able to find out from which fetus the fraction is coming. So it's always, if you're doing it for twins, in fact, the best screening method for twins is going to be the NIPT rather than the combined test or any other test for that matter. Because when you do an NIPT, if you have a SNP-based technique, you're going to look at the overrepresentation of the particular chromosome in those different cell fractions that you get. But otherwise, if you have just a pregnancy-specific risk, as far as chorionics are concerned, that's fine. But for dichorionics, that does not work. Because for dichorionics, if you have a pregnancy-specific risk, then you're stuck and you will have to go back to square one. So if you're doing it for twins, go for a SNP-based technique there rather than the other ones.
Okay.
Yes.
Let's
Correct.
take back with us, sir, because
Yeah. Now the SNP-based technique is not available extensively all over the country, although there is one, and we do have a very large unit in Delhi that is doing it routinely. It is more expensive, but it is truly worth trying. And while we are on this, can we also take up the queries regarding when do we screen and how do we screen for the vanishing twin in terms of specific weeks?
Vivek is back.
As soon as this question is answered, Nina, can you answer that question for us? In terms of a vanishing
Yes,
twin,
sir.
what should be the number
Yes.
of weeks?
So
Yeah.
regarding vanishing twin in the first trimester, when we see a fetal pole in the vanishing twin, it is advised not to go ahead with the biochemical screen because the biochemical markers maybe that is produced from the vanishing twin still would be present there and it can give false reports. Especially if the biochemical markers, the beta HCG is found to fade out quickly, while the PAPA takes time to fade out. So it is said that at least 8 weeks time should be there an interval between the fetal ball to be absent and then to go ahead with the biochemical screening. And in twins, there is not much role of doing a second trimester quadruple marker test. Then the next option available would be NIPS only.
And in general, what is the relevance of a quadruple test in terms of twins? How reliable, how unreliable? Should we do it at all?
It is not much reliable, sir, in case of twins. So it is not advisable. But there are centers where they are doing, but in our center, we are not doing quadruple marker tests for multiple pregnancies.
So will we all agree that we should not do it?
yes, sir. Actually, in India, I don't think we have a validation, but way back in 2008-9, when I was doing my fellowship in Australia, I have seen them doing cord screening for twins. But I really don't know how they managed to do it, but they gave twin-specific risk for quadruple screening also. But in India, we don't think we have a validation for second trimester screening as of now. So let us keep away from doing a second trimester screening for twins. Do your double marker. If you don't get that, as Vijay rightly said, go for your NIPS, then stop screening by biochemistry.
Yeah.
Will be the
So apart from the validation, we did realize very early in the evaluation of second trimester screening of twins by biochemistry that it's completely unreliable and should not be done.
yes, yes, sir.
Yeah. We'll come
That's
back to
one
the
take-home
question.
message. The gentleman is back. Vivek, we are welcome
Yes.
back.
So there we are. Vivek, there you are. Can we start off from where we stopped?
Yes, sir. Sorry for the glitch. I mean, we talk of high-end procedures, fetal procedures operating inside the womb. We still are struggling with the laptops and net connection.
Yes,
Sorry about that.
why not? Part of growing up.
Yeah. So right. So I would now move to the management of the TRAP sequence. As I said, this is best left to experienced fetal therapy centers because there's a lot of counseling that's involved, there's a lot of discussions to happen, and you need to, of course, take the right decision as to what could be best for the surviving, for the pump twin to come out unscathed in the whole process. Now, first thing to consider is genetic testing. We need to remember certain numbers here. 33% of all trapped fetuses or acardiac twins could have aneuploidies. And interestingly, up to around 8% of the pump twins could also have chromosome problems. Now, what we need to understand is that aneuploidy is not causative, but as I said, it could be one of the reasons that contribute to the initiation of the reversal of circulation between the two twins. And therefore, because of this incidence of chromosome problems, it goes without saying that a karyotyping or a microarray has to be offered in all cases of acardiac twins or TRAP sequence. Surveillance, well, of course, there's no universal strategy. The frequency of survival and how frequently you would want to follow up these babies would be dictated by the gestation age at which you see them, the severity of the condition, and of course, what is the protocol for fetal therapy in the center that you work with. Antenatal steroids could be given in cases where it is indicated. For example, if there's a late presentation, you're contemplating delivery, or you feel that the pump twin is going in for high drops and you need to deliver soon within the next 7 days, then of course there is a role for antenatal steroids. Well, management options. The conventional school of thought is to look at the volume of the cardiac twin as the cardiac function, because we said the cardiac function of the pump twin is going to be determined directly by the volume of the acardiac twin. Therefore, on your serial monitoring or surveillance scans, we find that the acardiac volume is increasing in size, and there are signs of cardiac strain in the pump twin, then there is a definite scope for fetal intervention. Whereas if the acardiac twin itself is small sized and there's no signs of cardiac strain in the other, there is probably a scope for a conservative management. Some of them could go on, some of them could spontaneously thrombose, while some could go on without much of a problem till 34, 37 weeks, and so on. Now, the first case that I showed you was a huge TRAP that presented somewhere around 24, 25 weeks. You could see that the volume of the acardiac twin was close to 1000 cc plus, and this was extracting too much of blood from the other twin, which is why the other twin was beginning to show signs of cardiac compromise. You could see a large dilated right atrium there. This fetus in no time would probably progress to high drops, and therefore there was a scope for an intervention, which is exactly what we did. And the treatment rationale in these cases, of course, as I said, this is the root of the whole problem. So the best option would be to occlude this cord so this fellow is capable of continuing the pregnancy till a reasonably safe gestation age. Now, for cord occlusion, of course, we know that there are three options. One is to an intrafetal laser, where you would block the cord inside the acardiac mass. You could also do a radiofrequency ablation, where again you would ablate the intrafetal portion of the vessel, or as was shown, you could also do a bipolar cord occlusion at the cord insertion close to the acardiac mass. But the problem with bipolar cord occlusion in a lot of these cases is going to be the fact that this cord is very often quite short and not as long as you would like to do a bipolar with. So, mind you, a lot of these TRAP sequence fetuses, acardiac fetuses, could have a very short cord with a single umbilical artery, and therefore getting access to 2 points in the cord, especially with the Momo twins, could be quite difficult. And therefore, bipolar is perhaps the least preferred mode of treatment for TRAP sequence. Now, this is the case that I showed you before. This is the vascularity that you see. You can see my needle being jabbed into this twin from the side. This is the 18-gauge needle that we use for interstitial laser. The needle comes right to the root of the vessel, perpendicular to it, not in contact, but very close till you reach the blood vessel there. And once you reach, you start shooting with the diode laser or the Nd:YAG laser, whichever you use. And you can see the laser energy being deployed to the hilum of the blood vessels. Here again, you can see there's just a single umbilical artery and an umbilical vein. So I said 70 to 80% of them do have only one umbilical artery. The laser energy blocks the blood flow into the fetus right at the hilum. And eventually, by the end of the procedure, you get a completely devascularized or avascular perfused twin. So this twin is no longer a perfused twin. So the acardiac twin that used to be perfused once upon a time from the other pump twin. 6 weeks later, this is what you see. You can see that the huge mass has significantly shrunk in size. All the edema and the cystic spaces have completely disappeared, and the volume has significantly come down from 1075 to 153 cc, almost 1/10 of what it was before the procedure. These were two babies at birth. This was the TRAP mass. This is where we went in for the laser. This is probably somewhere inside that we would have occluded these vessels. And you could see that the lower limbs are pretty much reasonably formed compared to the rest of the body. And this is how big the TRAP mass was at delivery, despite doing an interstitial laser. So you can imagine how big it would have been had we not gone in for a procedure. And this is the same baby at discharge. This was at 1 year follow-up. And this is when she started going to school. Always such a pretty picture to see your first TRAP laser doing so good. Now, the other option that you can explore is to do a radiofrequency ablation, which is the procedure of choice for slightly larger fetuses, wherein you're laser fiber may not be good enough to occlude the entire vessel. So if you see some fetus with a trap sequence at around 24 weeks or so, RFA might be a good choice. And of course, we discussed about bipolar. This is one case where we did a bipolar, but again, not the ideal case because you could have very short cords. This one had a reasonably good length of cord, so we went into the bipolar because that is what we had at that point in time. Now, here is data from Mediscan on intrafetal laser. For trap sequence, they assessed around 57 cases, of which 27 opted for interstitial laser. Median gestation age is 22.5 weeks. The earliest they did was 16.3 weeks because you cannot really put in a needle before that for safety concerns, just as you would not want to do an amniocentesis before 15 weeks or so. Now, they had a survival rate of around 73% of the pump twin, and they had a repeat procedure in just one case. So this goes to tell you that interstitial fetal laser is very much a feasible process, and it gives you very good survival rates for the pump twin. Now, talking of this last case where they did need a repeat procedure, we had a very similar experience. This is one of our cases. Here you could see that post-laser, the twin, the avascular twin, the acardiac twin is completely avascularized immediately post-laser. But one day later, you call her back for a check scan. That's always what you do. Any procedure you do, you call her back for a 24-hour follow-up. You could see again that the very faint trickle was starting to come into the fetus. I was worried for the other twin from examination. So you look at the Dopplers, the MCA Dopplers, for a 20-weeker, for an 18-weeker, 37 centimeters is borderlining on anemia. So this baby was starting to exsanguinate into the other one. For such cases, you might immediately decide to go in and do a relaser, which is exactly what we did. And you can see that post-relaser, the cord has been devascularized again. So yes, once in a while you might need, and you can see that there was no longer anemia in the fetus from there on. Now, of course, yes, you need to understand that even if you do an intervention, you might think it is completely devascularized. Remember, you're not tying the cord, you're not tying the blood vessels there. You're only lasering around it so that the vessel gets trapped in the charred tissue, and that might occlude the blood vessel. You might get spasm of the blood vessels in some case. You might think that the blood flow has stopped, but when you call her back the next time, you might see that it is starting to open up again. So such cases, once in a while, from time to time, you might require pre-intervention. So that is another concept that you need to take home. Now, we've so far spoken about managing twins based on the size of or volume of the acardiac twin and the signs of cardiac failure of the pump twin. Now, that was the conventional school of thought, but now there is a slightly different school of thought to managing trap sequences, particularly after this paper from St. George's group, where they looked at around 23 cases of trap, of which 17, I mean, all of them were counseled for laser. 17 of them opted for intrafetal laser. There were 6 fetuses that did not opt for intrafetal laser, and all 6 of them died between 13 to 16 weeks of gestation. Now, this could be a one-off situation. This could be coincidental, but their data suggested that you need to treat all cases of trap sequences because they opine that the close monitoring for cardiac strain does not really predict sudden fetal demise in the pump twin. Now, this is because over and above what you see, there could be some cases wherein you get a superimposed acute bleeding from the pump twin to the cardiac twin through the large artery-to-artery anastomosis over and above what is already there. Now, this sudden fetal transfusion that can happen through the anastomosis is completely unpredictable, as we heard Dr. Bijoy mention previously. And therefore, there is always a risk, irrespective of the volume or size of the pump of the perfused twin, that the pump twin may not survive the sequence. So therefore, they were of the opinion that you need to treat all cases of trap, irrespective of the size or volume of the perfused twin or the signs of cardiac failure or hydrops in the pump twin. Now, this at best was an observational study. It's only level 3 evidence as far as the grading of evidence goes. Therefore, we still are left with this question of whether to treat or not to treat trap sequences. There are 2 schools of thought. We've seen both of them, but there is still no consensus as yet. But slowly but steadily, we have more and more data coming in, including this from one of our centers, Dr. Pratima Center in Bangalore, where they looked at around 18 cases, 5 of which opted for termination of pregnancy. For the remaining 13 cases, 7 of them had interstitial laser. They had 100% survival. And of the 33% that were managed conservatively, of the other 6 cases that were managed conservatively, they had only 33% survival. So there is a statistically significant difference between treating versus non-treating. And therefore, there is more evidence that supports this that is growing from across the world. And therefore, there is conclusive evidence that says there is a high risk of spontaneous loss in untreated pregnancies with TRAP. And therefore, the again, this is another systematic review that gives you the same impression. It says you need to intervene to get a greater incidence of live birth. And this impact of treatment is going to be greater, especially if you have poor prognostic factors in the pump twin or the perfused twin, which includes hydrops or cardiac failure, particularly abnormal Dopplers in the pump twin, polyhydramnios, momo twin. Now these we know are predisposers for a high risk outcome. Therefore, if you find any of these and you treat them, the odds ratio for a good outcomes are 8.5 times than when you would not treat these cases. So therefore, there is consensus that's gravitating towards treating all TRAP sequence in modern day for the simple reason that one, as we said, cardiac compromise in the pump twin is completely unpredictable because you could have large sudden fetal-fetal transfusions. Second, as I said before, there could be severe dystocia at birth. You could have real tough time delivering a cardiac twin. Therefore, it would make sense to reduce them to a reasonable size so that you can deliver them. And third, of course, we have enough data from across the world that says fetal intervention by any of these three forms, particularly with intrafetal laser, is very, very safe an intervention to do in these cases. So for these three reasons, there is slowly but steadily consensus evolving that says you could go ahead with treating all cases of TRAP sequences. But the question of when to intervene is still unanswered because you have two schools of thought. One says intervene as soon as you find them out in the first trimester. So you can prevent fetal demises of the pump twin that happen between 13 and 16 weeks of gestation. But the other school of thought says wait it out till 16 weeks. Do not intervene. Do not poke in a needle into the amniotic sac or cavity before 16 weeks, just as you would not do an amniocentesis before 16 weeks, fear of increasing the risk of miscarriage. Now, there are studies that have said 12 to 14 weeks is a good time to do intrafetal laser. It is quite feasible, but of course, the loss rates are higher. Now, the final answer as to when you would want to treat TRAP sequences is expected to come from the TRAPPIST trial, which is still ongoing. Now, this is going to compare, this is a randomized trial which looks at early versus late intervention for TRAP sequence by Asma Khalil and group again from St. George's. Now, this is still ongoing, we're still recruiting. And as soon as this trial results come out, you would probably have an answer as to which is the best time to intervene in TRAP sequence. Timing delivery, of course, if it's conservatively managed, you could go on to 34 to 37 weeks, probably earlier if there are complications that develop to either of these twins. Cord-occluded cases can be safely taken till term. Of course, the mode of delivery would be guided by obstetric reasoning. Now, the fifth case is a very interesting case. Cases come in all sorts of formats these days. This was a case that came through WhatsApp. A friend of mine, obstetrician, sent me an image asking, please give an opinion. It is a momo twin, 7 weeks gestational age, primary spontaneous conception. One has fetal heart. The other mass is query a vanishing twin. So you can see that this is a fetus that looks white. Okay, this is again a blob of tissue that you see here. So I replied saying this is not, as you would say, a vanishing twin. This could be a TRAP sequence. Well, 2 weeks down the line, 9 weeks, she messages back saying, you are right, the mask is indeed vascular. You can see a small vascularity, but what I forgot to tell her is not to switch on color Doppler during the early first trimester. That's okay. She has put on color Doppler. You could see blood flow. And if you look very carefully, you can see the blood flow direction is into this fetus and not away from it, whereas this umbilical artery is taking blood away from this fetus. So she said, you were right, the mask is vascular. The other baby is fine. What should I do now? When shall I refer? 12, 13 weeks is okay. I said, yes, this now is definitely TRAP sequence. You would do well to please refer her at around 12, 13 weeks of gestation. Now, this is a very classical veneer that you would see in some of these cases of TRAP sequence. Very often get misdiagnosed as vanishing twins at 9 weeks or 10 weeks, or probably even before that. But when they come to you at 11 or 12 weeks of the first trimester scan, you would be surprised to see that the twin that was supposed to have vanished did not actually vanish. You switch on color and you would see blood flow into the fetus, again into the fetus in the umbilical artery. This would be pulsatile and it would show color towards the fetus in the direction of the fetus. So that tells you this is the umbilical artery with a flow reversal. Now this is different from the reversed end diastolic flow that we associate with FGR. This is completely reversed flow direction in the umbilical artery that I'm talking about. And that tells you that this is not a vanishing twin, but a TRAP sequence here again. Now again, here you can see the the 3 vessel cord on the other side, the 2 umbilical arteries. Here is 1 umbilical artery that is carrying blood. So this blood goes from here, comes through the anastomosis. You can see the anastomosis there, and then comes into the acardiac mark there. So that is TRAP sequence again. Now the concept that you would connect with this is that a Doppler is a must in all cases of suspected vanishing twins. One, of course, it might help to differentiate a TRAP sequence from a vanishing twin. And not just that, it also could help to differentiate a TRAP sequence from what is a severe anomalous co-twin. You could have that as well, a feature that is completely anomalous with a cardiac anomaly or an anencephaly that could also mimic a TRAP sequence. But therein you would find a well-developed heart, and therefore that will rule out any cardiac or a TRAP sequence. Again, if you look at the direction of blood flow, you would know that if it's a TRAP sequence, the blood flow comes into the fetus through the umbilical artery and not away from it. Now, the 6th case was again a spontaneous conception, 13 weeks, 3 days, second gravida. You see 1 normal twin here. Again, you see the blob of tissue here. This is now, from now, we know very clearly that this is again a TRAP sequence. Probably this is an acardiac twin here. Forget the name that you call it. This is TRAP sequence. Again, you can see the umbilical artery going there. That's the anastomosis. Closed cord insertion, and there is reversal of blood flow in the umbilical artery towards the acardiac twin. Now, this fetus at this gestation age was 5.6 cc in volume, the acardiac twin that I'm talking about. At 16 weeks, 2 days, she comes back. The volume of the acardiac has increased to 22 cc. But when I switch on color Doppler, there is absolutely no flow pickup. So this twin has become avascular despite increase in size. So it would probably have grown on for a while and then ended up being avascular. Now, this can happen because of spontaneous thrombosis. The blood vessel that I said that feeds the acardiac twin could be very small in size with a very, very high chance of spontaneous thrombosis. That's why a lot of these twins could undergo spontaneous thrombosis, which is one reason why people prefer to wait again to around 16 weeks, hoping that spontaneous thrombosis could still happen in the pump twin. Now, again, we followed up the fetus. The volume then decreased from 22 to around 8.2 cc, and the other twin, it stayed to be avascular, continued to be avascular, and the other twin grew normally and went on to the term. The last case, this is again a primary spontaneous conception, 8 weeks, 5 days, Momo twin. Again, you could see 1 normal fetus, the other vague looking mass of tissue. I very confidently now reported that this is most likely a TRAP sequence. I would definitely want to wait slightly longer before labeling it so, but then I was pretty confident in my mind that it's again nothing but a TRAP sequence that we are dealing with. And I gave, in fact, the TRAP volume measures 1 cc in my report as well. Now, 13 weeks, she comes back, and this is what I see. This is the fetus, the same fetus A that I'd called as TRAP sequence. That fetus now seems to show a very good head and the heart as well. But of course, you could see it's a severely hydropic. So this I thought was a misdiagnosed TRAP sequence. This is probably a severely anomalous co-twin with non-immune hydrops that you saw and thought was the acardiac twin. You could see a well-developed head, you could see a well-developed heart, and in fact, there was cardiac activity. It was not that there was no heart. This is the heart that I showed you. This had cardiac activity. You could measure the heart rate as well, quite normal for 11 weeks of gestation. But then on closer evaluation, the baby also had non-philocele. It also had cyanomelia. So I was quite stunned. In fact, I was trapped here, and I thought, how did I go wrong? This is not a TRAP sequence, but this is most likely an anomalous co-twin. So I was about to put down my report, but then that flash of thought occurred. Switched on Doppler, and this is what you see. You could see that the same anomalous twin had blood flow in the umbilical artery towards itself. It had a single umbilical artery again, blood flowing towards the fetus from the placenta. So this clinches the diagnosis that even though it looked like an anomalous co-twin, this was not an anomalous co-twin. This was indeed a case of TRAP sequence, as I had initially thought. So the concept is, remember that variability in presentation of the perfused fetus is the hallmark of TRAP sequences. If you remember that those amorphic forms that I showed you, some of them did have a head, some of them do have a heart. The only constant in diagnosing a TRAP sequence is the reversal of blood flow in the umbilical artery, not what you see in the so-called perfused twin. It could still have a heart, it could still have edema, it could still have hydrops, could still have a head. But if you see reversal in the umbilical artery to that twin, that is a case of TRAP sequence. Do not think any further from that. Now, the take-home point, well, TRAP is a complication that you would see only in monochorionic twins, and rest assured you would see it very, very infrequently in monochorionic twins. Reversal of blood flow in the umbilical artery, reversal of flow direction in the umbilical artery is the diagnostic key, whereas anatomical forms, as I just told you, could vary. Close follow-up and early intervention is the key when required. As I said, the consensus is moving more towards treating all these cases of TRAPs, but as things stand today, as such time till there is a randomized trial that says treat all TRAPs, intervention for all is still debatable. Cord occlusion, of course, would be the intervention of choice. There are 3 different methods to do it. Depends on your individual preference and on the case that you select to do it. And of course, that is the end of this concepts through cases lecture. Thank you very much for a patient listening.
Thanks a lot, Vivek. And for the last slide too, we started on the 6th of August, sir, and we have reached 7th, Khurana, sir, without even knowing that we have crossed the dinner time and towards the breakfast of the next day. And still I'm amazed to see there are close to 170 delegates listening to the passion of fetus. And how do you want to close this session, sir? I'm overwhelmed and I really want to thank you.
Yes, I thought we'll just take 10 more minutes. I want to congratulate Vivek also for that absolutely fabulous presentation. We've had absolutely marvelous presentations today. I think this has been truly one of the best sessions of monochorionic twins that I've heard in my life. And I've heard a lot of them, but nothing so precise. It's not just that knowledge has evolved. It's not just that definitions and protocols are in place, but we have an understanding, which is completely unique because in India, we have such a large number to deal with. And we really need to put all of this together, publish it as soon as possible and get credit. Some publications are already in place, but we need to move on to journals that actually have a greater visibility. Congratulations to all of us at the Society of Field Medicine to do this. And you can see you attracted so much attention. Dr. Mohit Shah has also joined us. He's our vice president, and I'm so happy to have him on board tonight. We'll take a few questions before we close. The first question, the very simple question, this is for Bijoy. Dr. Manohar wants to know if I have a positive SNPs, NIPS, which fetus is it? Is it fetus A, fetus B? Is it the fetus on the right? Is it fetus on the left?
No, that doesn't work like that.
Yes, thank you.
So the SNP tests, when you do, you know that it is positive for one or the other, because you're dealing with dichorionics, we have to test both of them. You cannot say that it is one fetus that is having the risk or not, because even though we give fetus specific risks, the importance is to understand the numbers behind that. When you say that fetus A is at risk and fetus B is at low risk, indirectly you're saying that one baby may have Downs, but both of them having Downs is going to be extremely rare. But because 1/3 of them are monozygotic, we have to test the other baby as well.
Perfect.
Yeah.
Very nice and clear. One very important question: at what level should we assess the umbilical artery sampling? Near the fetus, midway, or placenta when we're looking at twins?
I think they're talking about SFGR. In SFGR, it has to be sampled as close to the placenta as possible, because then alone can you classify between type 2 and type 3, because the pressure fluctuations may not carry on completely into the cord. So you look at it at the origin, and that's where you will pick it up. Unlike in IUGR, where we always take the mid loop to make our assessments.
Can I just add a point, Corona, sir?
Of course.
I'm trained by Dr. Smolanik, who was always doing the gradient flow in both SFGR and TTTS, where he used to do sampling at 4 sites. One is at the cord insertion, second is a free loop, third is the 2 parabladders. And his concept of doing that was, if the parabladders become absent, you still have some more time for the free loop and the placental insertion to get acted upon. So you have time to steroid and to act upon your Maxel, whatever you want to. But this has really worked with me also, because if the parabladders show good forward flow, I'm reasonably reassured without even telling the patient that you can come back after 3 days or 4 days to meet me. Maybe that is not in textbooks, but this is something which has helped me too. Just wanted to put it.
Yes, of course. And we have an article on that in, it's already been accepted at the Journal of Fetal Medicine, that the parabladder evaluation is truly very useful when we look at this particular situation. The question again from Dr. Deepak Varshini again is, how many times Should we take each reading before we accept it as okay? Do we take an average? Do we take the worst?
In what? In Doppler?
Yes, yes.
You take the maximum number of readings actually till you get
Mhm.
one that is closest to the lowest. Basically, it regresses towards the mean. So you take a number of readings till you get the closest to the normal, and that's what you will take. It's not the highest reading that you will take. So you have to take a number of measurements, make sure that the baby is not moving, the mother is not breathing. All those things have to be taken into account before you decide that, okay, this is the Doppler abnormality that I'm watching in this fetus.
Yeah.
So when you assess the Doppler, you cannot just jump the gun and take the first reading that you get. You have to look at all these factors before you actually say that this is the problem that I'm looking at.
Yeah. And then we have a question on the single deepest pocket, maximum vertical pocket from Nikita Jain. How do we measure it in twins? Bimal, would you like to take that question?
In the sense, we go about from one sac to another. And
Quite
see-
simple. It's exactly the same. There is no big deal. There is no magic to it. There is no super rocket science. It's very nice and simple. I just love these questions because we do want our members to express these simple questions because they do add up and build up to good practice. And some of us get embarrassed asking these questions. There is nothing to be embarrassed about. There's people like me who are still learning, so why not? The next
But
one.
never, sir, but never to do an amniotic fluid index, sir. Please convey that message.
Sure enough, of course, we already did. We're not going to do that one. There's a very nice, interesting case from Jyotsna Dumbre. And she says in an RH negative twin pregnancy, the peak systolic velocity in the middle cerebral artery is in C zone of the Murray's curve in fetus 1 and in B zone, non-anemic zone, in the second fetus in a 28 weeks pregnancy. How do I handle this report?
It's RH negative and it's DCD or MCD. I didn't get that.
Yes. So apparently that has not been mentioned in this particular thing. So let's presume that we have an RH negative pregnancy which is monochorionic.
No, if it is an RH negative pregnancy, then definitely we're looking at RH isoimmunization if she's positive, if she's ICT positive.
Yes.
Naturally, we go in and transfuse and correct the anemia.
Absolutely.
Now, if the other one is not in that, we'll have to test and find out why it is so. But it can happen.
Yeah.
It can happen depending upon the degree of transfer of antibodies to either of these fetuses. But if it is monochorionic, then there is this complication of TAPS also in there because it's 28 weeks. That's the time when TAPS can develop.
Mm-hmm.
So it's difficult to say. I would probably definitely test the baby that has high MCA PSV and go ahead and transfuse that baby, and also keep a watch on the MC of the other baby and see what's happening there, whether it is going down or if there is a difference in MCA PSVs on both these babies also.
Yes, and of course, referral to an appropriate center, counseling of the patient, and making sure that we send them to a place where the facility is available. There used to be a time when there weren't these facilities available. Now we have these facilities available, and we really must be able to handle this. One beautiful question. Ashish Panchal wants to know, how do you identify anastomotic vessels to perform laser coagulation in TTTS? Vimal, do we even need to identify these, or we just dichorionize the placenta?
No, we need to identify them, but then of course, I don't have any experience with laser, so I won't know how they.
So there is no ultrasound basis. So
so he's asking about ultrasound. Okay. Ultrasound we can't identify, sir.
That's right. And so Bijoy, what do you do?
Already Vivek gave a beautiful lecture last week on
Yes.
how to identify it. So I'll just go through the basics of it. We basically trace out one cord to the other and we watch the vessels that come out from one cord insertion to the other.
Yeah.
And usually the artery overruns the vein. So you will find both of them coming and joining into a central portion. And you follow one artery and see if there is a vein going back. If you find a solitary artery coming and there is no vein going back and there is a vein going to the opposite fetus, that is the anastomosis, and that's how you identify it. Or as again Vivek said in his last presentation, you identify the membrane and see all the vessels that are coming out from that membrane and trace them and find out where they're ending and if they form an anastomosis or not. And then we coagulate that anastomosis and try as far as possible to join the dots. But having said that, there are a lot of technical things on it. I think it's beyond our time here, but
Sure.
and on a nutshell on how we should do it.
So Vivek, I want the last word on this. Should we just routinely solemnize all placentas?
I think it is good practice because it's supposed to decrease the amount of the number of post-procedure TAPs and post-procedure TTTS or repeat TTTS, residual TTTS that you could have. So that is what the data says. But again, there are papers that have not found, for example, the paper from Eve still did not find a significant benefit with solemnization initially. But I think as you get more familiar with the technique and as you get more numbers accumulating over the years, I have a feeling that solemnization may in fact reduce the incidence of complications. Because I remember the last case, I did not do Solomon, and that ended up being TAPS, and then we had to do an RFA for the anemic twin. So yes, I think it's good practice. That's what is recommended now, to dichorionize the placenta so that you can minimize the extent of post-laser complications in either twin.
Yeah, for now I would.
It's not very easy to connect the dots. Actually, that's the thing. We can identify the anastomosis, we burn them, but connecting the dots is also a very difficult job. So I understand, like it's not possible in all cases. In posterior placenta, maybe yes, but when the placenta is anterior, we are struggling just to find the anastomosis, and then to draw a line is like going to be difficult. I think maybe over the years, maybe we will also learn to do it properly. But yeah, right now we try to solemnize as far as possible. Yeah.
Also, I think what's going to happen is that our instrumentation is going to change, and it's going to become a lot easier to handle the anterior placenta. Or we might suddenly decide that, okay, having a patient lying upside down is not such a bad idea. It could happen.
Yes,
we've done it in things before, and we could try it again.
Yes.
And we just might be able to have a lateral approach for all you know. As a team, we really struggle when we have to do this procedure in an obese patient, and I don't really mind putting it into a decubitus position when I approach the problem. So I guess it works.
Yes, that's absolutely right, sir. Because the instrumentation is the bottleneck here. Because burning a vessel is not something that's difficult, or even for that matter, identifying the vessel. The problem is actually to reach that vessel and burn it without causing much complications. So if the instrumentation develops to a certain level that it becomes easy and doable for everyone, I think it's not far behind when you will find that a lot of people will be doing laser.
Yes, and so we have fewer and fewer centers doing more and more work so that we develop the expertise in these centers, and we have a sort of nice hub and spoke pattern that, yes, all of us will do all of this screening, and then we send it off to a center which is truly experienced, and that is really the way out. And I think that's the way we should be going. We're truly running out of time, and so I hand the floor back to Dr. Vedilakshmi to close the webinar.
Sir, I really don't have words to say thanks to you first, because you initiated the whole thing, and Vishal stood with me from beginning till this moment. I'm not seeing Vishal anywhere, but I'll wholeheartedly thank him for all the supports. And without my panelists, this day would not have happened. So from Nina, who's the most junior young person in this panel, who has done justice to whatever she did, to you, sir, with the senior most panelists which I had, and I'm privileged to have you as my panelist and to moderate you all in this session, Bimal, Vivek, and Bijoy. And so amazing to see how they answer the questions. They're so confident in what they're doing, what they're talking about. That is a passion to the subject, sir. So before I close, I would like to thank Dr. Taseen Khan, who is my second year fellow FNB, who did a whole lot of job to put the slides together and to help me to arrange the whole thing. And I thank God Almighty to make this dream of Trivandrum study group of MFM to become a reality. And we'll come back with Bahubali part 2, as I have promised, where we'll have all these boys sitting with one topic each, talking about their passion, and then 3 and 4 in the coming events. Thank you, sir, for all your time, because you're supposed to reach the airport by 4 o'clock, which I know. And thanks for this late dinner for all of you. And thanks all delegates for being part of this first online session. Thank you all.
Thank you.
Thank you.
Thank you. Good night.
Thank you.
Bye.
Right.